Hello and welcome to the ACTRI Center for LifeCourse and Vulnerable Population Research Symposium today, titled Refugee Health, Research, Care, and Policy. We're very happy to have everyone here today, and we'll take a few minutes to just kind of do some brief introductions and housekeeping as people join, and then we'll get started with our actual agenda. So to give you a little bit of background, as I said, we're the Center for LifeCourse and Vulnerable Population Research. We are part of the Altman Clinical and Translational Research Institute here at the University of California, San Diego. And some of you may recognize us actually from some of the other symposia that we've done in the past when we were under the title of the Center for LifeCourse Research. And last year, we amended our title to pull in vulnerable population research. So now in the acronym we use is CLVR. And along with pulling in vulnerable populations into kind of our mission and what we do, we've kept a lot of the things the same. So we continue here at CLVR to offer symposia throughout the year. This is actually the second one we've done. Earlier in the year, we did one on COVID and disparities in COVID in the United States. And today, as you know, we're here talking about refugees and refugee health. So in addition to the symposia that we do, we have several other things that we do as part of our center. Those include pilot awards, and what you see here on the screen is our website where you can see all of this information as well. But we do pilot awards, and those are awarded with the general CTRI pilot awards, but there is a category specifically to LifeCourse and vulnerable population research. We also offer support for proposal development, both for those pilot awards, as well as just for any other grants that an investigator is applying for, where if you would need consultation on how to incorporate in either LifeCourse research or vulnerable populations into your research. And additionally, our center offers consultation on enrollment of specific populations of interest or consultation on setting those enrollment targets. For example, when you're applying to NIH awards or other awards where you need to set those enrollment targets, we will work with investigators to really look at the geographic landscape of San Diego to determine where the populations are of interest, how the disease of interest is distributed across San Diego County, and how you should kind of be thinking through setting your enrollment targets. And then we also collaborate very closely with Jesse Nadora and his Center of Community Engagement to also look at once you actually start your trial, how you can better target the individuals that you're interested in targeting. And actually, sorry, let me put it quickly here. Okay, in addition, we at the Center for LifeCourse Research have worked on tools for conducting LifeCourse research that can be accessed on our website, as well as we've put together a biobank of biospecimens that are available to researchers interested in accessing them, as well as different cohorts that are available for research, particularly research that pertains to LifeCourse research. Finally, some of the activities that we do in our center are to develop educational opportunities for students, trainees, and faculty on both LifeCourse research and vulnerable population research here at UCSD. What you can see on this slide, in addition to our website, are the members of our center. So this has changed recently, actually just as of the past couple of weeks. So you can see here part of our center are myself in a slightly younger version of myself. As well, we have Dr. Andrea LaCroix, who's in the Herbert Wertheim School of Public Health and specializes in aging and longevity research. Dr. Tala Al-Rousan, who you'll actually hear, she's a co-host of this symposium with me here today, and it will be our first speaker. And so I'll introduce her shortly. And then we also have Erin Delker, who is a postdoc here and at UC San Diego in the Department of Pediatrics, and is also a new addition to the Center for Vulnerable Population Research. And before we get started, we did receive some materials from Irene Garcia, who is at the EIS branch at the County of San Diego Department of Public Health, and she very kindly forwarded on information about the CDC recommendations for lead poisoning prevention in newly arrived refugee children. I've posted the document that she sent here, noting the prevalence of elevated blood levels among resettled refugee children being significantly higher than what we see in the general population of US children. In addition, through her work at EIS, they offer different handouts and pamphlets that can be given throughout the community. These are offered in many different languages, and I've put 2 of the examples here that they have available. I will post all of these to the Clever website, and Irene's contact information is also here on this slide if anyone wishes to reach out to her. So thank you, Irene, for passing along these materials to us. All right, so last we have the agenda here, which everyone should also be able to see where they logged in. But what you can see is that we've structured the day, so we'll have the 4 speakers in the morning. We'll go through, each speaker will be introduced and then talk for about 20 minutes. There will then be a 10-minute Q&A where our attendees can type questions into the Q&A or the chat, and we'll go ahead and after each speaker presents, we'll facilitate that Q&A. From 12:10 to 12:30, we'll have a lunch break. And then in the afternoon, we'll have 4 more speakers, and Dr. Al-Rousan will moderate those, introducing the speakers, the 10-minute Q&A following each speaker, and then around 2:25, we'll have our closing remarks. So without further ado, I'd like to go ahead and introduce our first speaker. So for our first speaker, we have Dr. Tala Al-Rousan. Dr. Al-Rousan is an MD, MPH, assistant professor and founding faculty of the Herbert Wertheim School for Public Health and Human Longevity, and an affiliate faculty of the Division of Geriatrics. Dr. Al-Rousan is trained in medicine and epidemiology in Jordan, Egypt, and the US. Her ongoing research focuses on designing evidence-based programmatic interventions and health policies that reduce health disparities, centering a human rights approach. Dr. Al-Rousan is a recipient of multiple awards, including an NIH K23 award, the Senior Atlantic Fellows Award from the Atlantic Philanthropies, and the American Journal of Public Health Award for Innovative Research in Aging. So we're very pleased to have Dr. Al-Rousan here today to present her work to us.
Thank you so much, Gretchen. Hello, everyone. It's great to see many familiar faces, colleagues from South Africa calling, Latin America, Europe. Hello to everyone. I hope you have a great day today listening to the amazing speakers that we have for the rest of the day. And let me share my screen and get started. So today we'll be talking to you about research along the migratory route. I have worked with refugees in Syria, in Jordan, and California. Many of the same refugees that came from Syria and stopped in Jordan for a few years ended up here in San Diego. So I'll be telling you some of their stories and the research that we're conducting along the migratory route. I'd like to start by reminding all of us that migration is a normal human behavior, right? It's the reason why we have this diversity in culture, innovation, science. It's really our nature as human species. We move around. However, displacement or forced migration is not normal. Also, the lack of response to the needs of the millions of people now that have been displaced is not normal. We know that there is a global anti-refugee rhetoric now that is escalating. We also know that the number of refugees are increasing. There's almost not a single country in the world that is not somehow dealing with the issue of forced migration, either by its own people being displaced or by having to decide on whether they would receive displaced populations or not. Here in San Diego, we have the largest borders with Mexico, and we have detention centers set on either side of the borders. We receive a lot of migrants from Latin America. We also are a major refugee resettlement hub, and I'll be talking to you a little bit more about this. But these are just images from different parts of the world showing how big of a problem displacement is. So I'd like also to share my own personal story with refugee health research and why I think it's a priority for health research in vulnerable populations in general. So here are some images from my ancestry, my family. So to the top left here, the little kid in the middle is my dad. And him and his family, they moved from Syria. They were displaced from Syria. They have sought political asylum in Jordan. And they took a journey on foot from Syria to Jordan, which took them about 3 days. And until this day, my dad tells me about this journey, how it's like to leave their homes. Although he was a kid, it did really impact his health. Up until now, we hear about these stories. Also to the right is a photo of my grandmother, and this little kid is my grandmother and her mom, who have fled Iran due to religious persecutions. They have fled to Palestine from Iran, and then after Palestine, they came to Jordan. To the bottom left is me in the ACTRI refugee camp in Jordan. This is the largest refugee camp for Syrians worldwide, and one of the largest refugee camps in the Middle East. It's home to about 90,000 Syrians. And Jordan in particular is the top refugee hosting country. So I grew up in Jordan, seeing camps become cities later on. So people have been displaced. They live the majority of their life in camps. And then these camps start losing their borders and become part of the nation, really, of the country, the fabric of society. So some of the refugee health research projects that I'm currently leading here in San Diego and in Jordan, the first one is in Alzheimer's disease. And this is really shaped by my grandparents' experiences. They both have been displaced, one from Syria and one from Palestine. They came and lived in Jordan, and they have developed both Alzheimer's disease. And I was always trying to understand whether the trauma that they've endured due to displacement has had some role in them developing Alzheimer's disease. The other project I'm leading here in San Diego is on uncontrolled blood pressure. We know this is a big problem in the refugee population. My dad, whom I said, also has been displaced from Syria, he has this issue where he doesn't like to adhere to his medications, and somehow always the conversation ends up being that the health system in Jordan is unlike Syria, and somehow he brings up his childhood experiences of being displaced. So I wonder if those experiences are now the reason, for example, for his health behaviors now. We also now are currently involved in a COVID project here in San Diego, where we're dealing with some vaccine hesitancy in the refugee population. And we're trying to really understand how can we gain the trust of the community by dealing with some of the vaccine hesitancy issues regarding COVID. I'd like to remind us also that terminology matters. We tend to lump migrants all together in one group, but they're very different groups. Those are groups of people with very different exposures, needs, and status. So a migrant is a generic term, right? And this is by the UN definition. A migrant is the person basically who moves from one country to the other. So I'm a migrant to the US, right? I came from Jordan, but I came willingly and I wanted to study here. I ended up living here. An asylum seeker, however, is a person who has formally submitted a request for asylum because of reasons for persecution. So the person who's seeking asylum, they are claiming that they have a reason why they can no longer live in their own country, and they are seeking asylum in another country. A refugee, and those are the populations I tend to work with the most here in San Diego and in Jordan, are people whose asylum has been processed and they've been granted asylum. So they went through court, the court decides, or the UNHCR, in the case of Syrians, decides that they do have their claim for asylum, is valid, and they're given then the refugee status. Of course, many of you here know that we are at all times high numbers of people who have been displaced. We've never seen these numbers before. We've had world wars before. We've had, many things that we know of in current history that have displaced people. But however, these numbers are the highest ever, especially with COVID. Now we know that COVID has raised inequalities globally, and we will see more and more people losing their jobs, losing their homes, increased rates of conflicts worldwide, there are displacing people. So now we have 48 millions who are internally displaced, meaning they are displaced within their own countries, within the country, the borders of their own countries. 27 million almost are refugees, 4.1 million are asylum seekers, and 4 million people are stateless. Basically, they have no rights in the country they live in whatsoever. We know also that 2/3 of all world's refugees come from only 5 countries, and those are Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. We know also that people are aging in exile. So now we need more thinking towards really a life course approach to try to understand the experiences of those who have been displaced. Many people end up living their entire lives in camps and dying in refugee camps. And they're really marginalized and understudied. We also know climate change is displacing more and more people. And there are talks now at the UN level on how do we start giving rights to those that have been displaced because of climate issues, drought, climate, natural disasters, extreme weathers, food insecurity. So we know that this is a huge problem that will only continue to escalate. We also know that the majority of refugees end up in the global south, in countries that are low and middle income themselves, countries that are struggling themselves. So for example, the country I come from, in Jordan, we are a huge refugee hosting country, meaning we host a lot of refugees. However, we ourselves in Jordan have our own issues, right? With food insecurities, drought, being surrounded by conflict zones. So we have to understand that the majority of the refugee health burden is being borne by countries that are struggling on their own. So countries like the United States and other high-income countries should really step up in contributing to sharing this burden with those countries. So San Diego here is a major refugee resettlement destination. This goes back to the fact that San Diego has been a naval base. So many of the people that fight overseas, the veterans, tend to tell countries and populations where they're at that San Diego is beautiful. You should ask to be resettled here. So we have special immigrant visas. Those are for example, in the case of Afghanis, for the Afghanis that help Americans overseas, they get this type of visa and get resettled here in San Diego. We also know that after the Vietnam War, a lot of Vietnamese have been resettled in San Diego. A lot of the resettlement agencies in San Diego here, they have been accustomed to resettling refugees. Thus, a lot of the people like to work with them, state and federal level. So this all contributes to the fact that San Diego is a major refugee resettlement hub. So the refugees in California, particularly in San Diego, the majority of them come from Iraq, Iran. We have a lot of Somalis here in San Diego, a lot of Burmese. Of course, more and more are arriving from Afghanistan as well. Also, I like to remind us all that migration is a social determinant of health. It cuts across what we call the social ecological model of health, which is really the basics of public health, how we like to think of health. That health is influenced by not just age, your genes. It's influenced by lifestyle factors, social and community influences, living and working conditions, general socioeconomic, cultural conditions. Those are all impacted when a person is forcefully displaced or moved out of their natural habitat. I also like to always think through my research about this graph here, that people are stories, right? So people are, it's important to understand where they're coming from when you care for them as a physician or a public health professional. It's also important to understand what happens during travel or transit. So as I said, a lot of the Syrians that I work with, they stop in Jordan for a few years, 2, 3, 4, 5 years, before they're resettled here in San Diego and in the US in general. So it's important to understand where they're coming from, what happened to them pre-migration, what happened to them in a refugee camp in Jordan, in Zaatari camp, for example, what kind of healthcare access they had, what kind of traumatic events they had. And also think about the place of destination. So are they going to stay in San Diego, or they're going to move to another route? So we know that San Diego, for example, the cost of living is very expensive, and we're seeing more and more refugees now being resettled first in San Diego, living for a few months in San Diego, and then they end up going elsewhere, somewhere to the Midwest or New Mexico, or places where they can afford living. And finally, thinking about return. So a lot of the refugees I work with really don't wish to live, along the migratory route like this. They want to go back home, where they started their lives, they made up their careers. Many of them are doctors, teachers, engineers. They want to return. However, as we know, a lot of them, their countries are shattered with war and continue to suffer. So they end up living in that secondary place of destination. This is a picture of Damascus, which is the capital of Syria and is believed to be the oldest continuously inhabited city in the world. That dates back to at least 11,000 years. It's beautiful. We used to go grab lunch in Damascus. It was a beautiful, beautiful city. This is Damascus in 2009. And 2 years later, these are the scenes that are seen in Damascus. It was declared by the UNHCR, the United Nations High Commissioner for Refugees, as the biggest humanitarian crisis of our time. It's a country that has produced a large number of refugees. And San Diego here has resettled actually the highest number of Syrians that the US has taken. So my journey in research, I've done a lot of research with other populations similar to refugees, like prisoners, for example. I've studied mental health in prisons. I've also looked at mobile home dwellers, older adults that end up living in mobile homes because they can't afford living in a normal house, so they end up living in trailer parks. I've also looked at those who have been affected by disasters, natural disasters. The Harvey hurricane that happened here, the storm that happened in New York, was something that I looked at, disaster preparedness in older adults. And we found that older Americans in general are not prepared for natural disasters, and many of them have lost their homes. So what do these communities have in common? Mobility or lack of, right? A lot of refugees live in refugee camps, and actually the average stay in refugee camps is 15 to 20 years usually. Institutionalization, right? People are living now somewhere in an institution, right? Migration detention center, refugee camps, prisons, trailers. Those are all some kind of institutions. Marginalizations, human rights. Refugees in particular have been used as a political bargaining chip for many countries. So many of them are suffering the lack of a human rights approach to their health. All of these populations have been displaced, right? So I truly believe that displacement lies at the intersection of many issues, such as race, socioeconomic status, social determinants of health. Those are all poorly understood and understudied. So we need a better way of looking at refugee health, really looking at, using a multidisciplinary lens. One of my mentors at Harvard is Dr. Bernard Lown, and he has won the Nobel Peace Prize because he prevented basically a nuclear war from happening between the US and Russia by producing science. And the science that he was producing was really talking about what will happen if we had a nuclear war back then, what would happen to humankind. And I'm hoping to do the same through science. So really trying to leverage science and refugee health research to try to tell the stories of populations here that are being left out or marginalized. There is ACSD here, a US Immigration Policy Center, that has produced an interesting report that's gained a lot of media attention recently with COVID, showing that a third of San Diego's essential workers were immigrants. Many of those immigrants came from countries such as Syria, Kenya, Sudan, Iraq. So really the narrative that refugees are coming here to use our resources and be a burden is actually not true. These same refugees that come here want to start new lives, want to step up in things like, our response to COVID. So it's our moral obligation here as a country to really also not just offer them refuge, but also to continue to think about their healthcare after being resettled. This is a map of San Diego, just to kind of also illustrate what happens to refugees after they resettle. So first they arrive at our airport here in San Diego, and they find some resettlement agencies, 4 of them that are here in San Diego, the Jewish Family Services, the Catholic Charities, the African Alliance, and the International Rescue Committee. Those are major resettlement agencies that work with refugees once they arrive. They work closely with the HHS to do health screening within 30 to 90 days. We at UCSD have been helping with that, as well as other community partners such as the Family Healthcare Center of San Diego. We connect refugees to services such as Medi-Cal, adult education, coupons, housing. However, beyond those 90 days, refugees are left on their own. So many of them end living in areas such as City Heights and El Cajon, which are to the south here in the East County. And we know that the East County, for example, 23 to 30% of all residents there live below the poverty line. The majority of refugees who live here come from East Africa and the Middle East. There are ethnic community-based organizations. We have speakers here from an ethnic community-based organization later in the day that I'd love for you to hear from her. But they work closely with refugees later on to become this trusted party in the community, offering services to connect them more and more. But I want you all to imagine how it's like when you arrive in a new country, very foreign, different system, and all what you're given is 90 days to connect with all these various types of services, and then you're left on your own in the community. I'm taking you back to the Middle East here to Jordan, which is again a major refugee resettlement destination also in the Middle East, a country that's surrounded by conflict zones. However, to the north of Jordan, there's the highest concentration of Syrians here. So the majority of Syrians live in Turkey, Lebanon, and Jordan. And the majority of them, of course, live below the poverty line. Only 15% of refugees live in refugee camps, and those are usually the ones that cannot afford outside. So they live in refugee camps that are run by the United Nations High Commissioner for Refugees. However, those who can afford to live outside, which are about 80% of all Syrian refugees, they live in the community. These are pictures from Zaatari camp of some of the patients that I see, the Syrian refugee patients. And this family in particular, I can never forget when they came to me and they started talking about being forgetful more, talking about mental health trauma, and trying to discuss with me, how could that impact health in general? And that's when I started looking at the literature, not finding much out there, and started thinking about how we can come together as a group of scientists and researchers and think about moving along the agenda on refugee health and kind of really thinking through how we can produce more research with these communities. So again, along the migratory route, I really think a lot can be done. It's very important to understand where people stop in transit, such as in Jordan, and try to conduct research there before they get resettled in San Diego. So in Jordan, we have multiple projects that are looking at the role of encampment on cognitive aging. So whether living in camps really affects your cognitive health. We've learned a lot about orphans, for example, and orphanages that, they don't end up doing well. Their cognitive function is not as great because they've spent the majority of their life in orphanages. And I'm trying to understand whether living in refugee camp does the same thing. These are some of the pictures. This is an aerial view down here of the Zaatari refugee camp. And this is some of our pictures conducting research with refugees in the camp and to the right here in the community. Here in San Diego, we're looking at hypertension, self-management in refugees. As I said before, uncontrolled blood pressure is a big problem in refugees. So we're trying to understand whether an intervention where they can self-manage, meaning self-monitor their blood pressure at home, can really impact their behaviors and their blood pressure control overall. As you know, there are a lot of challenges for working with the refugee populations as well as opportunities. Some of the challenges, again, that, you know, as a researcher, you feel you're dealing with a lot of issues beyond your capacity, such as economic insecurity, you know, language and cultural barriers when accessing healthcare, social disintegration, negative social selection, meaning some, you know, certain refugees tend to be selected to move to the United States, such as, you know, older, abled, skilled refugees, while, sorry, younger, abled, skilled refugees, while older adults tend to spend the majority of their lives stuck in Jordan or other countries. We also know that it's not easy to conduct research with these populations. You need time to build trust over time. You need ethical approvals, you know, to make sure that you are not harming this population, but rather really working collaboratively with them to produce science that they want to tell, to produce the stories that they want to tell about themselves. So lastly, I'd like to talk about opportunities and policy and what we can do. So today we'll be listening to amazing speakers. I'd like us all to take that opportunity to learn about their research and what they're doing, and maybe reach out to them and think about ways we can work collaboratively. Because of course, you know, us alone here sitting on the West Coast can't do much. So I think the opportunities lay in these four main areas. Clinical care, I think we need more trauma-informed care, culture-sensitive care, holistic care when we're dealing with refugee patient population. Advocacy, we need a multi-layered approach. So community-based organizations who are here with us on the call, you know, globally, different agencies and foundations working on refugee health. We need to work more collaboratively together. So us as scientists, we can produce the science, but, you know, we need more advocacy. This science can be a powerful tool to change policies. Equity, social and political determinants of health, those should be always talked about. And now COVID has taught us many lessons about social and political determinants of health, that the most marginalized in communities cannot keep on being marginalized. We need to really bring them back to the center. Justice, you know, we need to think about innovation in team-based care. How can we make sure that the care that we deliver and the policies that we design are just and fair to these communities? I've been writing a lot. So some of these, the op-eds that I've been writing out there, really trying to talk about my own experiences, you know, coming from a multi-faith, multicultural, you know, household, and moving to the United States here, working with refugees. What is it really that I believe is the missing piece? So future directions, those are more maybe research focused, but I think there's a huge potential to do more research with and for refugees. I think there's a need for more longitudinal research in general. Most of the refugee health literature out there is really cross-sectional. So it's giving snapshots of what's happening. So we talk about a certain refugee population, there's a high prevalence of blood pressure. But what happens when people move from one place to the other, from Jordan to the United States? Does their blood pressure worsen over time? What happens, you know, what happens when there's interrupted access to healthcare? What is it that happens in one country that another country could learn from? I think there's huge potential to do this kind of cross-country global research that is looking at refugees longitudinally. I also think there's a huge potential for working more using technology. So for example, now during COVID, although COVID has been disastrous in many ways, we've learned also that virtual interventions are working for these populations. You know, a lot of people don't know, but refugees rely heavily on their social networks via smartphones and computers to talk to their family members all over the world. So actually one of my projects now is heavily relying on that, on social media and smartphones, on measuring blood pressure and keeping refugees informed. I also finally think that there's a huge need to use a multidisciplinary lens to understand refugee health. So today we'll be listening to speakers from social science, anthropology, engineering, medicine. I think there's a huge need for more and more of these symposiums like today and these gatherings where we sit together and think through how can each of us contribute to refugee health research in general. Lastly, these are some of the collaborating organizations here in San Diego that we work with. A huge shout out for the Family Healthcare Center of San Diego, the clinics in City Heights, and and El Cajon that work closely with us, they see the majority of refugees, and many of them are our research participants. We have the UCSD Center for Community Health over here that is home for the Refugee Health Unit. The San Diego Refugee Forum, which is a beautiful initiative here in San Diego that brings different groups of researchers, parties in general that are interested in refugee issues, lawyers, even schools that are homes to, that are seeing a lot of refugee students. And finally, I'd like to thank you all for being here today. This is a wonderful opportunity to get to know you. So I'm looking forward for the Q&A. Thank you.
Wonderful. Thank you so much, Dr. Al-Rousan. That was a perfect presentation to start off the symposia, and really, I think, did a great job of kind of explaining where we're at, explaining some of the terminology that you'll hear today throughout the presentation, as well as setting up really nicely for our future speakers who are going to address multiple of the topics that you heard in this first presentation. So please feel free to enter your questions in the chat. I will answer one question that we've gotten. The entire recorded Zoom presentation will be made available and posted to the Center for LifeCourse and Vulnerable Population Research after the symposium, once it's recorded and downloaded and touched up, and we will put it out there. So let me go ahead and open it up to any questions that anyone has.
Hi, Camelia. I see your comment. Camelia Lata from UCSF is joining. Hi, Camelia. Great to see you.
All right, and we have a question here in the Q&A. After a refugee becomes a citizen, should they still be referred to as a refugee?
That's a great question. That's something that actually is of interest for me to answer. I still don't know the answer to that, because many of the refugees that I work with, actually, when I ask them, do you like to be called a refugee? Many of them say no, because many of them prefer, for example, in Jordan, to be called a guest, because mentally they like to feel, to think that they're either returning back home or moving to another destination, their dream destination, either in Europe or the United States. However, I think personally, from my own experience working with different policymakers and different agencies, I think it's important for us to acknowledge refugees as refugees, so that we are able to allocate resources and understand the human rights related to being a refugee. So actually, it's a badge of honor to be called a refugee, and many of the refugees also tell me that it's something they're proud about. So I get mixed answers, from refugees themselves. I personally think it's important to call a refugee, because again, it's a human experience, it's a human story. So really allocating resources, for example, such as foundation grants, or one of the grant proposals that we just wrote to the Robert Wood Johnson Foundation, for example, is looking at how can we create a better community health worker model that is refugee focused. Meaning these community health workers, how can they get out in the community and become more, focusing on refugees? So really specialized care for refugees. I think we need more and more of that, such as the Promotores model, for example, that is being used for the Latinos here in San Diego. It is called the Promotores model, and it's really focused on Latinos. So why can't we do a refugee-focused model? So thank you for that question. It's a very important question.
Okay, next we have another question here in the chat. It says, what role does the general population play in shaping all the rhetoric surrounding the refugees? What can we do to help?
Another excellent question. Thank you so much. I think, the general population, it's extremely important to acknowledge that there are a lot of misconceptions, right, in society that are shaped by social media, by politics. So in different countries, refugees are viewed differently. So I think the first we could do as the general population is educate ourselves, right? So for example, the first step is try to understand what's the difference between an asylum seeker and a refugee and a migrant. That is a great initial step. So a refugee is a person whose asylum has been granted, their cases have been processed, there's definitely a claim, and this claim stands true, right? So the general population, first, you should really try to understand these differences. Second, I think, again, as I said, start writing op-eds, do things advocacy-wise. I think, discussions on a dinner table with your family, start talking about these populations. These are all populations among us, and we interact with them some way or one way or another. So I think first educating ourselves, and second, trying to do some advocacy in whichever capacity, whether you're a student, as a researcher, a policymaker, just trying to acknowledge the need for a better way to give refugees their rights, and then do as much advocacy as you can.
All right, wonderful. Thank you so much, Dr. Al-Rousan. And we actually do have a few other comments that have come into the chat. In the interest of time, I'm going to go ahead and move forward, and the panelists can see into our chat. And so hopefully they can address some of these questions as we go along, or as the Q&A are moderated as well. All right, so I am very happy to introduce our next speaker. We have Dr. Linda Hill. Dr. Hill is a professor and interim assistant dean of the Herbert Wertheim School of Public Health and a professor in the Department of Surgery, Division of Trauma at UC San Diego. San Diego Family Care, a federal 330 community health center, is the site of her clinical activities as medical director from 1980 to 2001 and senior staff physician since 2001. She's a director of the UCSD SDSU Preventive Medicine Residency. She's the executive director of the Asylum Seeker Shelter Health Assessment Program since December 2018. And we're very happy to have Dr. Hill here to talk to us today about her experience with asylum seekers in San Diego. So Dr. Hill, I'll go ahead and have you share your screen.
Thanks so much for having me. Can you both see and hear me? Is that an affirmative? Yes. Okay, thank you so much. Well, thanks for having me today. And
Dr. Hill, we can't actually hear you. I don't know if you're okay.
Okay, can you hear me now?
Yeah, sorry, it was probably me. Go ahead.
Okay, no problem. We'll take two, right? Well, again, what a wonderful way to start the conference. I'm just delighted to be able to speak with you today. And I'd like to tell you that I have no conflicts of interest, and that I'd like to start with political threats to asylum seekers. Asylum seekers come from across the globe, as we've heard, seeking a safe harbor. They're fleeing often violence and persecution, and have often experienced trauma in both their home country and en route. In the past, most non-sanctioned border crossings were driven by the need for migrant labor in the US. However, in the last 5 years or so, with increasing social disruption, that has shifted to individuals and families seeking asylum. For example, the Northern Triangle of Central America has suffered devastating civil wars, resulting in a loss in infrastructure and leadership, with gangs roaming the country and controlling their territories, well armed. The Mayan communities, women and children are targeted, and the latter are pressed into gangs or killed if they won't comply. Families leave with their children to avoid losing them to the violence and to seek a better life. In one report from Médecins Sans Frontières, 62% of migrants and refugees interviewed had been exposed to violence in the 2 years prior to leaving their home country, with another 57% reporting having been attacked during their journey through Mexico. I've heard this many times, that the journey itself is fraught with danger, For example, one family reported leaving with his wife and his 6-week-old and a 2-year-old child because the gangs threatened to kill him. He made it to Mexico with his family and got on a bus only to be robbed of everything they had by a drug cartel who stopped their bus. The Tijuana San Isidro border crossing is the busiest border crossing in the world, with 180,000 crossers a day when our border isn't close to only essential traffic. And even then, it's 110,000 crossers. Our Cali Baja region is united by mutual interest, economies, and cultures. And in addition to the back and forth of workers, students, tourists, and families at our border, we've always benefited from our immigrant and migrant populations. And they've played a part, and we have played our part in accepting refugees and asylum seekers from around the world. However, the prior administration slashed refugee quotas and created inhumane policies against asylum seekers that included the inaptly named Migrant Protection Program, unprecedentedly forcing asylum seekers to wait in Mexico for their hearing, often in highly dangerous settings, such as shown here. Is everybody able to see my slides?
No, we were not able to.
Ah.
Thank you. If you can try sharing again.
Okay, that is right. Okay, let me see if we can. Well, it is hard to identify the most egregious of the policies of the last administration. Certainly, the separation of children from their parents is something I thought I'd never see in this country. There was a calculated attack. This was a calculated attack on humanity, taking children from their parents, some babies, with no method to keep track and no strategies for reunification. As we speak, a reported 2,127 children are still not united with their families, and this is likely a gross estimation. The asylum seekers were detained in jail-like conditions. My colleagues, immigration lawyers and pediatricians, sued the government to get access to the detention centers and said they had never seen such terribly depressed children held in cages, despondent and mute. This drawing is by a 10-year-old who wasn't separated from her family, but depicted the jail-like conditions. In addition, the courts were stacked with anti-immigrant judges, and the asylum seekers were not given adequate legal representation. In 2018, ICE stopped a service they had been providing asylum seekers to reach their sponsors suddenly and started releasing them to the streets without money or knowledge on how to travel to their sponsor family. This is an example of a drop-off in Texas in 2018, similar to what was happening here. So in the fall of 2018, hearing about this, a group of nonprofits known as the Rapid Response Network began working to pick people up and set up a shelter in Imperial Beach with Jewish Family Services, one of the humanitarian refugee resettlement agencies, taking the lead for the RRN group. After many meetings with ICE and Customs and Border Protection, the latter agreed to bus asylum seekers to the shelter rather than street releasing them. I will tell you, however, that even after the shelter was set up and this arrangement was made, and after we had this system, we would still get calls from McDonald's in San Isidro or the bus station that lost-looking individuals or families had been dropped off there. One day in my job at the CHC where I work, I was called because they brought a woman in labor to McDonald's, and a JFS employee asked me what to do. So we ended up counting contractions to help decide transportation options. We at UCSD were asked to help the shelter starting in Christmas Eve of 2018 because of our 12 years of experience in running the Refugee Health Assessment Program with Catholic Charities. We were asked to screen individuals before they entered the shelter to avoid the transmission of communicable disease to other shelter guests or to the public before they traveled to their sponsor. We also provided other medical care and care for people after they entered the shelter, since many problems only appeared the next morning. This is a map that we keep at our shelter. This is the one we had in our pre-COVID shelter to help orient people to the US geography, as many had no idea whether their sponsors were a short bus ride or a flight away. These are pictures of the shelter that we used pre-COVID, having to move twice after this due to losing our space. The first shelter, the upper left, shows the congregate sleeping arrangements of our shelters pre-COVID. On the upper right is the picture of the old family courthouse, which was torn down in January of 2019, and before our third shelter was occupied. This particular building had unstable electricity and no air conditioning. And the last one was right next to Highway 5. The home countries of our guests listed here haven't changed much since the pre-COVID days. During our first round of the program, pre-COVID, we saw nearly 19,000 people in 16 months. This slide doesn't tell the story of the complexity of having to staff 7 days a week with wildly fluctuating daily arrivals, ranging from 0 to 270 in any given day. We ended up with physicians, nurse practitioners, translators, site coordinators, volunteers, residents, and students coordinating with Jewish Family Services and the county nurses. In all, we had well over 160 people involved. This table lists the most common diseases we saw pre-COVID. One of the things I'm most proud of is our very low rate of referral to the emergency department, less than 1%. We have a policy of not separating children from their parents. If a single parent's referred to the ED, a JFS volunteer goes with them to provide someone to watch the child while the adult's being evaluated. And sometimes this requires some education of the charge nurses. We also saw other conditions, some of which are listed here. We had to make decisions about management of these conditions based on the challenges of shelter living. For example, on Christmas Day 2019, we had a guest with a postpartum psychosis. She had a 3-day-old newborn, a 2-year-old, and a very overwhelmed husband. She spoke Creole and her husband spoke some French, which I do, and we had a language line, but communication was difficult and she was very agitated. She was scaring the 2-year-old and unable to care for her newborn. Our doctors were watching the baby. So we reached out to a wonderful UCSD-based psychiatrist this Christmas Day and asked for a consult. Knowing that she had a mother in Florida, he advised us to give her just enough medicine to get her to sleep on the flight. And indeed, we did that, and she arrived safely where she had support and care. It's not a decision we would have made if she was staying in San Diego. We were, so I want to move on to what's been happening since the Biden administration and the changes in immigration policy. The first is that individuals who were sent to Mexico under the Migrant Protection Program and having to wait in Mexico for their asylum hearings are being allowed to enter the United States and come into our shelter again. Attempts are being made to unify children with their families. There are programs for unaccompanied minors, and Title 42, a statute that had been used to justify deportation of asylum seekers, is being reversed. We were asked to restart our program in February, but with the new processes needed to accommodate the pandemic. Our screening and stabilization program now includes screening for COVID-19 with PCR testing at one site and rapid testing with PCR backup at the second site, as well as screening for symptoms of COVID-19 and screening and care for other medical problems, as you've heard. We coordinate closely with the county and the state public health department to manage the complexities of COVID and other communicable diseases in these settings. Indeed, we communicate with them daily. Such are the issues that arise with other potential communicable disease being diagnosed downstream, perhaps varicella outbreaks in our with our colleagues let us know about the camps in Mexico, or our colleagues who are providing medical services in CBP detention centers, letting us know that they're seeing various infectious diseases that are going to influence our care once they reach our shelter. We currently have 2 shelters, and because of COVID, we've moved away from the congregate setting, and we're working out of 2 hotels so that each family can be housed individually in their own hotel room and reduce the chances of disease transmission. We are looking, because the good news about the reversal of Title 42 is that many needy people will be admitted to the United States. The challenge is that we are going to greatly need to ramp up, and we've been very busy to date. We have admissions 7 days a week. We're providing services in multiple languages, and people are being brought to our 2 shelters literally day and night. Because of COVID, the issues around some of the other respiratory diseases have actually gone down, but we've had to deal with issues around COVID-19. The current protocol is that anyone who's diagnosed with COVID-19 by rapid testing or PCR go to the county's COVID housing, which is the Crown Plaza Hotel, and they're managed there during the time of their isolation. We're also seeing more mental health conditions, some of this related to the adverse political climate created by the last administration, with people having waited sometimes several years in Tijuana. We've had many conversations about how to provide better screening for mental illness, but we've been challenged by the nearly 100% responses to basic screening questions about anxiety and depression. We've gotten creative. We've posted signs in the guests' rooms so they know how to reach us privately. And when we had a congregate shelter, we embedded LCSWs kind of into our staff with the humanitarian workers who could more casually approach our guests and see if they needed someone to speak with. I attribute our successes in providing high quality care in this vulnerable population and unorthodox setting to the tight protocols written by our medical director, Dr. Kathleen Fisher, and with input from our county public health communicable disease partners. This is the list of protocols that we have that address the common things we see, I kind of hanker back to the pre-COVID days when scabies was such a worry for us, and we were so concerned about it as a communicable disease, but we still manage it. So, for example, here's our pregnancy protocol, and because our guests have not had prenatal care and we don't always know where they're going and what that care is going to be, our protocols are a little more aggressive than some of you might have seen when you're thinking about providing prenatal care in a kind of supported environment. And we have a very low threshold for sending people to the emergency room if they have high blood pressure, for example. On the other hand, we have a somewhat less aggressive policy about not traveling women. For example, the story I told you about our guest with a postpartum psychosis. Well, it is better to be with your family in the immediate postpartum period. So we try to travel people who can safely do so in close consultation with our OB partners. Just another example, there have been, as I said, outgoing outbreaks of varicella in the migrant camps in Baja. CBP also tries to identify them at crossings so that those individuals with varicella can be brought to our shelter in a small bus and not with our other guests. But sometimes people are afraid to say they have a rash, or they don't know that it's varicella. And so we don't find out until they've arrived. By that point, they've traveled to our shelter with perhaps 25 or 50 other guests, necessitating that we go room to room and screen people for vulnerability to varicella and pregnancy. Because of the dangers of varicella in the non-immune pregnant woman, we send all of our pregnant patients to the emergency room so that they can get tested for immunity and given passive antibodies if they're negative. There have been many challenges and ongoing challenges to the work that we're doing. One in this atmosphere of COVID is keeping our staff safe, making sure that they're vaccinated, making sure they're wearing appropriate PPE, following the protocols exactly. We have a self-swab system for our guests for COVID-19, but I've done many of these visits myself to the hotel rooms, and at first we had people standing in the doorway, but we realized that we were creating aerosol in the process of getting self-swabs by sneezing and so on. So now we have people, we put in a doorstop and have people step back into the room. And I just tell you this by way of some of the details that we have to attend to in order to manage this system in a safe way. Challenges continue in the volume of arrivals and maintaining high quality across teams. We have many clinicians and our community health workers teams. We want them to follow protocols very strictly. And so we do a lot of quality improvement and team huddles. Additionally, we have to communicate closely with our humanitarian partners, Jewish Family Services at one of our shelters and Catholic Charities at the other. They're not all medically trained, so we have to make sure that we communicate very well. So in conclusion, public health at the border is a group activity, and this is just an incomplete list of the participants on this project and some of my other projects, both the School of Public Health and the School of Medicine with the residents, medical students and faculty who give up their day off to come work at our shelter, the residencies and nursing schools across the region, our wonderful San Diego Department of Health Services, specifically Doctors McDonald and Shaw, our humanitarian partners, and the many state agencies who are daily at our shelter, Customs and Border Protection, and for our larger efforts in the region, we've partnered with the Tijuana Chamber of Commerce, UNHCR, and the two consul generals, Sue Sarnia and Carlos Gutierrez. Thanks so much for your attention. Should you be interested in participating, we are always looking for help.
All right, wonderful. Dr. Hill, thank you so much for that presentation. Please go ahead and type your questions into the Q&A is better. It's a little harder for us to manage the chat, and we'll probably actually close it in a few minutes. But so please go ahead and type your questions into the Q&A. In the meantime, Dr. Hill, I would like to ask a question about the last slide you had about the ways that people can help. So particularly for non-clinicians, what are the ways that people can help?
Sure. We use the expression community health workers, but for us, those are our staff who meet with the guests and at one of our shelters where our staff are directly collecting the swabs for COVID-19 PCR. They go door to door in the hotels. They also ask them about any health problems that they're having. And we have a mechanism where they report it to the clinicians who follow behind them. And the clinicians then get these consults and go hotel room to hotel room, addressing the health needs of our guests. So those are not licensed positions. And some of our community health workers are actually many pre-health students at UCSD and SDSU and elsewhere who we've trained to do this work and are really excited to be working with our wonderful guest population.
Wonderful, thank you. And let's see. I don't see any open questions in the Q&A right now. Oh, actually we do have. So someone has asked if you can share where to go to volunteer. And a second very similar question, is there a website that I can sign up to volunteer?
Well, that's so nice to hear. You know, I would just email me, llhill@health.ucsd.edu. I would love to speak with you and find a way.
Wonderful, perfect. And okay, let's see, I don't see any other questions. All right, I have another question for you. So where, in terms of where we're at right now with the new administration, but probably also still, I imagine, huge numbers of people coming here seeking asylum, where do you see this? How do you see this resolving? You know, how do you kind of see the way that we're going to get through this?
I'm sorry, I'm just putting my email in the chat if anybody wants it. I don't know if that went through, but
yeah, and we actually have a similar question to that. What do you see the sustainability of this program long term?
I think that there's a lot of work to do. The last 4 years have been really difficult, and there's that has been the part on the US side, and on you know, on the global side, there's incredible ongoing social disruption, climate change, and conflicts. So the need continues to be great, and I think that we're going to need to have ongoing programs that are in place to address the need from around the world. The volume is definitely going to go up before it goes down, and COVID has made this ever more challenging.
All right, well, thank you. And I see we do have your email now in our chat, so I think that we're good there in case anybody would like.
Thanks so much for the
They get bombarded now, Linda, after putting your email in the chat.
Sure. Thank you.
All right, well, thank you very much. All right, we'll go ahead and move on to our next speaker. So we have Dr. Rita Hamad here today joining us from UCSF. Dr. Hamad is a social epidemiologist and family physician. She's the director of social policies for Health Equity Research Program, and she conducts research examining the effects of social and economic policies on health disparities. Part of her agenda involves assessing the effects of immigration policies on health, including the work she'll be presenting to us here today. So Dr. Hamad, I'll have you go ahead and share your slides and take it from here.
Can you see the notes view or the actual presentation?
So it looks like we see the presenter view right now with the notes.
Does that look right?
That's good.
Okay, great. Great. Well, thanks everybody for being here, and especially to the organizers for inviting this presentation. The topic that I'm going to be talking about today is looking at the long-term effects of neighborhood disadvantage among refugees. And this is quasi-experimental evidence from policies in Denmark and Sweden. I just wanted to start off by acknowledging our study team, which spans researchers at Aarhus University in Denmark, Lund University in Sweden, and then my home institution at UCSF, and then also acknowledging the NIH grant that funded this research. So as an overview of what I'll be covering today, I'm going to first talk about the importance of neighborhood context for health for refugees and among the broader population. I'm then going to talk about the natural experiment that formed the basis for this particular study, which is refugee dispersal policies that occurred in several European countries during our study period. I'm going to talk about the specific designs that we used in the studies I'll present today. And then finally, I'll go over the results and implications of our findings. So let's start with this conceptual diagram, which shows the ways that neighborhood environments and particularly neighborhood socioeconomic disadvantage might matter for the health of marginalized populations. So this includes social interactive features like social networks and relative inequality, environmental features like physical surroundings and pollution, geographical features like walkability and public services, and institutional features, things like schools and healthcare services. These might all affect individual health behaviors like physical activity, nutrition, as well as physical and mental health outcomes like heart disease or depression. One thing that we worry about is that the relationship between neighborhood factors and health might not be truly causal. In other words, there might be other things about people who live in disadvantaged neighborhoods that might make them more unhealthy, like their family's socioeconomic status, particularly if they are coming in as refugees. Or for example, pre-existing health conditions as well. So this isn't just a methodological question, but it also has practical implications for deciding whether we want to use our limited dollars to intervene at either the individual level or the community level to improve health. And of course, randomizing people to disadvantaged neighborhoods is not really practical or ethical on a large scale to try to answer this question. There is one study in the US, the Moving to Opportunity study, that randomly assigned low-income families in 5 US cities to a voucher program, allowing them to move to a low poverty neighborhood. And they found small but statistically significant reductions in obesity and type 2 diabetes. Of course, these results might not generalize to other people in other cities or rural areas, or to refugees who face particular challenges related to language, personal exposure to violence, displacement. This might make refugees even more vulnerable to the effects of neighborhood factors, or alternately, this new exposure might be less important relative to the trauma of their prior experiences. So this question has taken on a lot of significance given the influx of refugees to high-income countries in recent years that Tala was describing. And this figure shows the number of refugees admitted to Denmark, one of our study countries, each year. And you can see at the tail end here, the number is rising in recent years. And this has actually escalated even further after this figure was published. And the recent wave that has dwarfed this prior wave that I also have depicted here. So the first wave, it took place in the 80s and 90s as a result of a lot of global episodes of displacement from different regions. And in the talk that in the studies I'm going to be talking about today, we're going to focus on this earlier period. And it was actually, it's funny, a couple of years after I started doing this research, I realized that my own family immigrated from Lebanon, like during this exact wave. We weren't refugees, we would be classified as migrants, according to the definitions given earlier, but I realized sort of the relevance of this research for my own work that I didn't even think about when I started it. So during these years, the congestion in major cities in Denmark was rising due to this influx of refugees. And the government implemented dispersal policies, as they were called, that assigned refugees to neighborhoods across the country in a nearly random fashion, kind of like an RCT, a randomized controlled trial. So the placement officers, the government officers, would assign refugees to neighborhoods where families would also receive language classes, job training, free housing, and over 90% of refugees agreed to participate in the program. And since the refugee applications only had a few family characteristics listed, this means that the assignment by placement officers was essentially random, conditional on these characteristics, all of which are observed in the National Register data in Denmark, so we can include them in our analysis. This is just to show a parallel figure from Sweden, another one of our countries that we did studies in. And again, it shows a similar influx of refugees during the 1980s to 90s, when there was a similar dispersal policy in place in Sweden too, again with similar benefits for refugees who participated and similarly high take-up of the program. This next figure is a map of Denmark in the years before and after the dispersal policy went into place. It went from 1986 to 1998 in Denmark. And it shows the percent of the population in each municipality from refugee sending countries. And you can see that in 1985, these were highly concentrated in a few cities, but that after the dispersal policy, there was more even distribution across the country. Again, here's a similar map for Sweden in the years before and after the policy went into place in that country, which was 1987 to 1991. And again, you can see the same sort of more even distribution in later years. So in terms of the study design, in Denmark, our sample included about 49,000 refugees who arrived as adults during the years of the dispersal policy. The outcomes included a range of cardiovascular risk factors and outcomes listed here. And the data were drawn from national health registers, including inpatient, outpatient specialty, and prescription drug files. Unlike in the US, Denmark has universal health care, so we're not worried about missing diagnoses or other kind of biases due to people's lack of access to healthcare. The main limitation of these data is that primary care diagnoses aren't available. So in Sweden, again, parallel study, the sample included 61,000 refugees. In this case, our sample was those, again, who arrived from refugee sending countries during the years of the dispersal policy, and those aged 25 to 50 on arrival. In one of the analyses that I'm going to talk about today, we were looking at type 2 diabetes as the outcome. And in another one, we were looking at mental health as captured by diagnoses for depression and anxiety in particular. Again, we used inpatient, outpatient, and prescription drug registers. And again, Sweden has universal health care. And again, these data don't include primary care encounters. The primary exposure variable was a composite measure of neighborhood socioeconomic disadvantage in the neighborhood where refugees were assigned on arrival. And we constructed this composite index using something called principal components analysis. It basically combines a lot of variables into one sort of composite variable. And the variables were derived from the total population register, which is similar to the US Census. In Denmark, the composite measure was made up of 8 different variables that we had access to, including education, income, unemployment, welfare support, violent crime, poverty rates, percent of people who are foreign born, and the Gini coefficient, which is a measure of inequality. And then in Sweden, we had access to a smaller range of variables, so the composite index was made up of education, income, unemployment, and welfare support. So our analysis included linear regressions and Cox survival models adjusted for the covariates listed here. We excluded those who were diagnosed within 2 years of arrival, since those are probably pre-existing disease rather than the effects of neighborhood context in Denmark or Sweden. And if anyone's interested, I can go into the technical details of the models in the Q&A, but I'll skip over them for now. So here are the results from the analysis examining the effects on cardiovascular disease in Denmark. And these estimates come from linear models. And so the coefficients you see are basically represent a change in the percentage point risk for each outcome. So in both unadjusted models, which are the blue circles, and adjusted models, which are the orange circles, we found that neighborhood disadvantage resulted in increased risk of hypertension, hyperlipidemia, diabetes, and myocardial infarction. And each of these represent about a 2% increase from baseline for each outcome for every unit change in the deprivation index. So this is a modest effect, but definitely significant and would change the distribution of disease at the population level when you have thousands of refugees. And we didn't see any association with stroke, although this was a pretty rare outcome because this sample is relatively young. For the Swedish sample, we found similarly an increased risk of diabetes in both unadjusted models above and the adjusted models below. These estimates represent odds ratios from logistic models, and the exposure is a categorical variable. So for example, that very last estimate at the bottom, this would be a 22% increased risk of diabetes in high disadvantaged neighborhoods compared with low disadvantaged neighborhoods. And this seems like a larger percentage than the prior figure, but actually they're roughly comparable. It's just that this exposure is categorical and the previous one was continuous, so slightly technical, but in this case, you can see that when you're going at the extremes from low to high disadvantage, it's a pretty sizable effect of neighborhood context. So interestingly, for mental health, we found no effective neighborhood disadvantage on arrival with depression and anxiety among refugees to Sweden. Those are the gray squares in these figures. We did find an association among non-refugee immigrants, who are the black circles. Importantly, I should say that these other immigrants are not quasi-randomly assigned, but they rather self-select into neighborhoods. So we can't rule out the possibility that those who already had mental health problems selected into disadvantaged neighborhoods rather than that the neighborhoods affected their mental health. And interestingly, when we look at the effects of where these refugees and non-refugee immigrants were living 10 years later, the association between neighborhood disadvantage and mental health problems was even stronger. Again, we can't tell whether this is due to sort of increasing self-selection of those people or the effects of neighborhoods themselves. So to summarize in a few key points, this set of studies suggests that neighborhood socioeconomic disadvantage does matter for refugee cardiovascular health across multiple country settings. Potential mechanisms include the reduced availability of healthy food and safe spaces, fewer or more stressful jobs for those who are able to get employment, higher levels of pollution, or differences in other types of resources. We didn't get into each of those different pathways, but in future research, we plan to sort of disentangle the composite index that we had to look at specific pathways to see which might be more important. The results are less clear for mental health in Sweden, although this is sort of a spoiler alert, we just finished analyzing the same mental health question using the Danish data, which is not yet published. And we did find a strong effect on mental health for refugees. So the Swedish results that I presented today might be due to something specific about that group of refugees or the neighborhoods where they were placed in the Swedish context. In terms of policy implications, there are a few possibilities. One is trying to nudge incoming refugees to more advantaged neighborhoods. Another is adding resources to the neighborhoods themselves. Again, as I mentioned, the studies here used a composite index of neighborhood disadvantage. So we can't tell based on these studies what type of intervention would have the most meaningful effect. So that's something that we're planning on working on and that could be tested in future work, testing actual interventions at the neighborhood level. And finally, a big question, particularly at the symposium today, is what these studies mean for the US setting. Unfortunately, it's almost impossible to do research like this in the US. On the one hand, there's no such natural experiment that happened in the US where we had sort of this quasi-random assignment. But more generally and more fundamentally, there's almost no systematic data collected longitudinally on refugees beyond a brief survey that the government does within the first 90 days of arrival. So this is a major area of need since you can't evaluate or intervene on things that you don't measure. And there's also the question of generalizability, since of course Denmark and Sweden are very different than the US, as everyone I'm sure knows. And if anything, the robustness of the resources and safety net programs available in Scandinavian countries means that their disadvantaged neighborhoods are nowhere near as under-resourced as disadvantaged neighborhoods in the US, such that the effects of neighborhoods in these countries, in the US, are probably even more stark than what I described today. So thank you everyone for your attention, and I'm happy to take any questions.
All right, wonderful. That was a great presentation, and really kind of nice to see the use of this natural experiment, to start answering questions like this. I invite everyone to put questions into the Q&A, and I can go ahead and start with a few questions as well while we wait for that. So my first question for you was, if you could just kind of set the stage a little bit for, like, you showed the variation in Denmark and the variation in Sweden by where people moved around. But when we think about somewhere like Denmark and Sweden, I'm wondering if the variation between locations is kind of as stark as you would see somewhere like the US, and especially given, as you mentioned, access to universal health care and probably a stronger social safety net in places like that. And so I'm wondering if we would expect in the US to see even greater effects from neighborhood level factors than you saw in Denmark and Sweden.
Yeah, that's a question we get a lot. And I think that it's definitely true that the difference between disadvantaged and advantaged neighborhoods in Denmark and Sweden isn't as big as it is in the US. It's still pretty big. Excuse me. That there are differences that we can see in our data. And when for the beginning of this project, well before COVID, we actually traveled to Denmark and walked around some of these neighborhoods so that we could get a sense as researchers, not just like doing the research from thousands of miles away. And there's definitely, like differences in, graffiti and the types of resources available in the neighborhoods, things that you could sort of indicate that there's like a higher level of neighborhood disorder or disadvantage. But again, in the US, that's much, there's like the disparity is just so much bigger in terms of neighborhood disadvantage here. So we would certainly hypothesize that it makes an even bigger difference here. Although again, as I said, it's hard to do that research here, given data constraints.
Rita, great presentation. Thank you so much. This is Tala. Rita, what can we learn from Denmark and Sweden about the healthcare system and how we collect data on refugees here? There's a huge limitation for doing refugee health research in the United States because we don't have this kind of registry or, some type of data collection, sources that are readily available. So can you talk a little bit more about how in the US, if we're thinking of rethinking the way we collect data and do research with refugees, can you tell us about your thoughts on that?
Yeah, I mean, I think the lack of data available on refugees, sort of long-term data, systematic data, is a symptom of a larger problem in the US, that we actually don't have great longitudinal data on the population in general, which makes it really hard to evaluate sort of the long-term effects of social and economic policies. And that extends to refugees. And so I think, there's definitely, at the moment, we sort of collect data just on arrival in those first 90 days. And I think what would make, evaluating programs in this population more doable is extending that data collection. And I don't know that, I think ideally this would be done by the government, because the government are the people who process the applications. They know where they landed. They can probably more easily keep track of where they move, because of course, like, this is a very mobile population, as we've heard. And, barring that, I think there's space for like academic institutions, nonprofits to step in and try to collect that data more longitudinally to understand people's trajectories, their needs as they move through their time in the US or if they leave the US. And then deciding like what are the best interventions based on that information. But I think, barring that information, it's really hard to know what to do on a population level.
So I have another question for you. As we kind of think through, you had talked about, is it possible to put people into different neighborhoods, given what we see from these results? But I think one of the things I was thinking of, because we also know though that there is also economic instability that comes with refugee populations, and being able to kind of afford to be in select neighborhoods. And so I'm wondering if potentially a different kind of policy angle would be that as people are resettled into communities and neighborhoods that we know are disadvantaged, if kind of more money and resources follow them, to try to kind of mitigate some of that impact of going into a neighborhood, that we kind of know as researchers may increase the risk of adverse health outcomes.
Yeah, no, that's a great point. And I sort of mentioned quickly that, but it bears repeating, that in Denmark and Sweden, in both cases, when refugees were placed in a neighborhood, they were linked up with job training, language classes. The housing was free. It was like supported by the government. They weren't just like placed somewhere and like left to fend for themselves. And I know in the US, that's a little bit antithetical to the, mindset of everyone fend for themselves and pick yourself up by your bootstraps and whatever. But for such vulnerable populations, I think, that's something we can learn from the Danish and the Swedish models. Again, maybe not just for refugees, but for marginalized populations in general, that to really take advantage the most of the neighborhood where you are, you need a lot of those resources to really make it.
And, kind of to Tala's point earlier in her presentation, I think it's also important to remember some of those initial selection factors of the people who even make it into,
Right.
third countries for refugee resettlement, that there were, were the selection factors she talked about, that it tends to be younger and healthier, which may actually diminish also some of those differences you see from neighborhoods, just given that there was somewhat already of a healthy selection factor there to begin with.
Yeah, definitely.
All right. Let's see, I don't see any questions in the Q&A. So, all right. Well, thank you very much,
Thanks
Dr.
for
Hamad.
having
That was
me.
a great
Yep.
presentation.
Okay.
All right. So I will go ahead. We'll have a few extra minutes here for our last presentation for the morning session. So I'm happy to introduce Dr. David Fitzgerald to the symposium. So Dr. Fitzgerald is the Theodore E. Gildred Chair in U.S.-Mexican Relations, Professor of Sociology, and co-director of the Center for Comparative Immigration Studies at the University of California, San Diego. Dr. Fitzgerald's work on refugee issues includes the award-winning Refugee Beyond Reach, How Rich Democracies Repel Asylum Seekers book that has been in press since 2019. So we're very happy to welcome Dr. Fitzgerald here today, and I'll go ahead and let you share your slides and take it from here.
Terrific. Well, thanks very much for the introduction, Gretchen here. Can you see my slides?
Yes, we see them in the kind of slide view with the little tabs on the side and the big one in the middle.
Okay, you don't see my full-on slides.
No, we don't see them in the presenter view.
Not them here. Okay, let's see here. Okay, well, just for the sake of keeping the trains running on time, this is
that works.
This should be close enough. So I just want to take a few minutes to talk about the U.S. refugee policymaking context and how we got to where we are right now, why we have a refugee policy in the first place. Despite being famously a nation of immigrants, the U.S. didn't have a systematic form of refugee resettlement policy or even asylum policy until after World War II, with some minor precursors before that. The policy really came out of the failure of the Western democracies to protect European Jews during Nazi times. And on the screen here, you can see an image of a visa application from the Frank family. Otto Frank was a German Jewish merchant who fled persecution in Germany for the Netherlands. He was hiding out with his family in a hiding place until they were finally discovered and sent to the camps. And many of you will be familiar with his daughter, Anne Frank. So, they were one family of many who very directly, because of the failure to open the gates to people seeking refuge, died. So that was a really important part of the US policymaking context, along with the impending Cold War. So the US has settled quite a few refugees since the end of World War II. The vast majority of them were coming from communist countries. And ever since then, I bring up this history in part because US policy has systematically been a mixture of realpolitik considerations as well as some humanitarian considerations. And you can see that in the selection of which groups are allowed in, which groups are excluded. Today, our refugee policy is under the aegis of the Immigration and Nationality Act, and particularly some amendments to that act in 1980, commonly referred to as the 1980 Refugee Act. And what that did was put US policy in the same, under the same concepts, using very close to the same language of the international definition of refugees, going back to the 1951 Convention and that's 1967 Protocol. In practice, though, through the remaining years of the Cold War, we saw a very strong preference for people coming from communist countries as opposed to, say, right-wing dictatorships. The way the policy was set out in 1980, and which continues to this very day, is that the president decides how many refugees will be resettled in a given year, and then breaks those down by regions of the world with a number that can be allotted on a discretionary basis. And that's done with the theoretical input of Congress, although in practice it tends to be highly asymmetrical as something that the executive decides. So you can see over the years that the numbers of resettled refugees have really plummeted. They've gone up and down during certain periods. The last, in 1980 here, you can see a very large number. This is in part the results of the outcome of the Indo-Chinese wars and the US losses in those wars, and US allies, South Vietnamese, Cambodians, and so on, Laotians coming to the US. You see a big dip, then it starts to come up again. There's another dip after 9/11. But what's really striking in this graph is just how gutted US refugee resettlement was during the Trump administration, where the stated goal of the architect of the administration's policy, Stephen Miller, was to bring refugee admissions down to zero. Since Biden was elected, refugee admissions have crept up, but are nowhere near their historic level since 1980. The administration has said that its target for this current year is 62,500, but that in practice, it won't reach that, that maybe next year the numbers will be higher, but all of that is not nailed down at all. So takeaway point is that we are at some of the lowest levels of refugee resettlement in US post-war history. Where are refugees coming from? Looking from bottom to top, you can see that these countries are not simply communist countries as they were for most of US refugee policy history. So Burma, Iraq, Somalia, Bhutan, Congo, Iran, Ukraine, Cuba. You can come up with a number of different explanations for why people are coming from each of these different countries, but it's clearly for a much broader set of policy reasons than simply trying to shame communist governments by showing that their citizens were voting with their feet against communism and for capitalist democracy by leaving. There's a complicated mix of humanitarian reasons, foreign policy reasons, who has lobbies in the US who are effective on their behalf. It's a much messier kind of context to explain post-Cold War. So far I've been talking about people who have been resettled into the United States, and I know this builds off our previous discussion with the previous panelist, people who were selected, say, in a refugee camp in a foreign country, went through an extreme vetting process, and really, as large as that number might seem, that 5 million people have been resettled as refugees in the US, today only about 0.5% of the world's refugees are resettled in a given year in one of these overseas resettlement programs, historically dominated by the US, Canada, and Australia. So that's a tiny fraction of the world's refugees that ever even get into a resettlement program. Now, a different pathway to try to seek sanctuary in the US is through asylum. So in the US context, we talk about asylum in the sense of people who are at US borders, at a US airport, or they're already inside the United States asking for asylum. There are a couple of different ways that people can try to get asylum. There is an affirmative application, that is, someone reveals themselves to US government and says, I would like to ask for asylum. Then there is a defensive process of people who are in deportation proceedings, so-called removal proceedings, which is the government euphemism for deportation. And they make a claim that if they were to be deported, that they would be persecuted on one of the 5 convention grounds: their race, religion, nationality, political opinion, or membership in a particular social group. And that therefore that would constitute refoulement, and that they, which is illegal according to US and international law, and therefore they should not be deported. So in dark blue, you have the affirmative applications over time. In light blue, you have the defensive applications. The defensive applications of people who are already in deportation proceedings have become much more important in recent years, and in part because since the latter part of the George W. Bush administration, through Obama, through Trump, the US has been carrying out deportations at a historically unprecedented level. Which nationalities are granted asylum? They're all over the map. The asylum process is such that the asylum can be granted by an asylum officer who works for the Department of Homeland Security, whose job is to adjudicate asylum cases. In case of a negative decision, that can be appealed to an immigration judge who can grant asylum. So the process has a bit more autonomy on the part of the actors to decide who's going to get an asylum, compared to, say, the Refugee Resettlement Program, which is run by the Department of State and closely reflects the interests of the executive. So you can see here in 2019, for example, Venezuelans, Chinese, Egyptians, these are people who are being persecuted on very different grounds. Chinese, for example, typically are making claims based on violations of reproductive rights. And so again, the rationales for granting asylum are much more varied now than they were in the Cold War. Now, the denial rate, the percentage of applicants who are in the end denied asylum, varied tremendously by nationality. As much as we hear in the news about Central American asylum seekers at the US-Mexico border, it's very difficult for most Central Americans to successfully make an asylum case. And for Mexican nationals, even more difficult to successfully make a case for asylum in the US. So the denial rate is north of 80% for all of those nationalities that I just mentioned, as opposed to, say, nationals from the People's Republic of China, where about only a quarter of them are denied. There are also various forms, and there have been various forms historically of protection without granting asylum. So the most important one today is temporary protected status. That's been around since the 1990 Act. And temporary protected status has a lot of executive control around it. So the Department of Homeland Security designates certain nationalities. And this is something that only applies to people of those nationalities who are already in the US. And they cannot return for one of several different reasons, having to do with natural disasters or armed conflict, some other extraordinary situation that makes it difficult for people with that nationality to return to their country of origin. So they're able to temporarily stay in the US, and sometimes this temporary designation stretches on for many years, but it's temporary, which means that people are not on a path to citizenship. It means that they are not able to reunify with their family members, for example. So they're able to legally work. It's better than nothing for people with that status, but it's not like refugee status where people are on a, very quickly they have a legal permanent residency and they're on a path to citizenship, and most avail themselves of that opportunity. Okay, so those are the main paths: a refugee resettlement, trying to ask for asylum, but the US government, like all Western democracies, systematically tries to prevent people who are fleeing persecution from reaching their territories and able to be able to ask for asylum. To be able to ask for asylum, remember, you have to be on, say, US territory or at the border, at the airport border, at the land border, at the seaport, in order to be able to ask for that. So what the government does is make it almost impossible for someone who's likely to ask for asylum to ever reach the country. And today you can see this quite visibly if you live in San Diego and you go down to the border with Mexico at the San Isidro Tijuana crossing. And this is a policy that's only been around for a few years, is that right on the line, which I hope you can see in the screen here, right on the line between Mexico and the US, it's that metal kind of horizontal, or rather a diagonal line there, and from the bottom left to the middle of your screen, that is the exact line down to the inch of the division between Mexico and the US. And so US agents, or sometimes private security guards that they've hired, stand right on that line. They put their boots right on that line and check that passengers who would like to go into the US, or people in transit who would like to go into the US, have a US visa, or that they have a US passport, that they're already US citizens, or that they're legal permanent residents. And US government has always checked people's, well, they've often, for a long time, they've checked people's papers, but usually that's done farther into the border crossing area. Now they're doing it right at the line because they don't want someone to step their toe, literally step their toe into the US and ask for asylum. So this is a mechanism for pushing asylum control away from the US borders, measured down to the inch, and push them onto the soil of other countries or into international waters. Since the Reagan administration, the US has had a concerted effort of trying to keep potential asylum seekers from reaching US soil to be able to ask for asylum. You can see that through 2015, which is the last year for which the records are publicly available, about 250,000 people were intercepted by the US Coast Guard, mostly but not exclusively in the Caribbean, trying to reach the US. Many nationalities, but dominated by people from Haiti and Cuba. Now, if you are following the news at all, you know that in both of those countries, there's a lot of political turmoil now, and a lot of analysts are expecting that we may see more such interceptions in the coming future, in the proximate future, of people trying to leave those islands and being intercepted by the Coast Guard. We can talk about those details later in the Q&A if anyone is interested. As I suggested before, one of the things the US is trying to do is use its neighboring countries as buffer states. This is most prominent with the case of Mexico, which buffers the US from Latin America and also people from around the world who might be trying to transit through Latin America into the US. There are many other buffer states around the world. The US itself is a buffer state for Canada. This is something that became heightened and very prominent during the Trump administration. The general idea, though, has been going on for a very long time. And going back to 2012, in a rare moment of candor, a top DHS official, Alan Burson, declared that the southern border of Mexico and the state of Chiapas is de facto the southern border of the US. And using a number of different techniques going back to the Reagan administration to try to bottle up Central American refugees, particularly from Guatemala and El Salvador, transiting Mexico for the US. That policy has continued in various iterations up to the present day. And
Dr.
this graph,
Fitzgerald, I don't think your slides are advancing on our side anymore. So
Oh,
we're
they're
still
not.
seeing protection without asylum.
Okay, can you see them?
Yes, now they're
Can you see them?
moving.
Okay, great, thank you. So yes, so this is an important graph just to take a quick gander at. These are deportations of 3 Central American nationalities, Guatemalans, Salvadorans, and Hondurans. In red, you have deportations carried out by the US government. In blue, you have deportations carried out by the Mexican government from 1990 to 2018. If you were to update those with the last couple of years, you would see an increase, but it would not be exceptionally high compared to these historic levels. The point I want to make here is that the Mexican government has long been doing the majority of the so-called dirty work of migration control to intercept Central Americans trying to reach the US. So this again, this dates back to the administration of George H. Bush, Bush 1, Clinton. It's really a continuity more than a new development that we see the Mexican government involved in that work right now under a quite severe US pressure. Something else the government does that's much more quiet, much less visible, much less of a spectacle, but that arguably has the most important effect on making it impossible for the vast majority of people seeking sanctuary to reach our shores to ask for asylum, is by creating a dome, if you will, an aerial dome over North America, so that to even get into North American airspace, you have to have a visa. You might think that that's normal, that you have to have a visa to travel. That's a pretty recent idea in human history. That's really a post-World War I policy, that systematically people who want to go to a foreign country would need to get permission from that country before they even leave their home country. So that's a fairly new idea. The airlines have been de facto deputized to do the work of migration control by checking those visas before passengers ever board their flight. There are all kinds of incentives that government set up. They sanction air carriers who transport inadmissible passengers to make sure that those companies will in fact do that work. Then there are also various other kinds of programs that try to keep asylum seekers at a distance. There are pre-clearance programs that the US has. For anyone certainly who's flown from Canada to the US, you're familiar with this, but about 15% of US international passengers arriving in the US have been pre-cleared. They've gone through US Customs Control, US Immigration Control in a foreign airport, but talking to US officers. And the US plays with jurisdiction in those spaces. So on the one hand, the US government has prosecuted people for violating US smuggling laws, smuggling goods in those spaces, but it's impossible to apply for asylum under US law in those spaces in an airport, say in Abu Dhabi or in any of the major Canadian airports. So a whole host of techniques to try to keep asylum seekers at an arm's length. Okay, let me finish just a little bit with the public opinion context. So what you're looking at in this graph is a summary of US public opinion on mostly particular refugee groups since World War II up to close to the present. And in yellow, you can see the average support for admitting refugees from those identified groups. And in red, you see the average percentage opposing them. The big picture here is that overwhelmingly, the US public has opposed the admission of any particular groups of refugees from the beginning, with one exception, which is European refugees right after World War II, when there was a slight majority or a slight plurality, really, of people who were willing to accept refugees coming from communist countries. Other than that, and certainly if you look at the views of Jews trying to reach the United States, for example, even Jewish children in 1939, there has been overwhelmingly negative public sentiment towards accepting a particular group of refugees. Having said that, just in the last several years during the Trump administration, actually, there have been some important shifts. So despite that overall historic pattern, we see that opposition to refugee admissions, and the flip side of that, support for opposition has been decreasing. Support for refugee admissions has been increasing. It's not a huge effect, but it's measurable in the last few years, such that now there's actually more support for, say, generic refugees, if you're not specifying a particular group, like, say, Syrians. If you're just saying, should the US accept more refugees generally, there's actually a bit more public support for that now than there has been for most of the last 70 years. There are very large variations, though, by social group in terms of whether there is support or not for refugee admissions. I'm not sure how well you can see these two slides, but let me just summarize them. The first is that what are the groups that are most likely to support resettlement, specifically the resettlement mechanism? Typically, it's people who vote Democrat, younger adults, women, highly educated people, Black Protestants, Catholics, and the religiously unaffiliated. They're much more likely than other Americans to support refugee resettlement. Something new is that there is a much larger partisan divide around refugee resettlement. Historically, this has not been a strong partisan issue. Both Democrats and Republicans have typically agreed that it is in the best interest of US foreign policy and stated principles of humanitarianism to bring in resettled refugees. And now there is a growing split. It's not a complete cleavage. There are plenty of Republicans who support refugee resettlement, but there is a much larger partisan split on this issue, as on many other social and policy issues just over the last few years. So that is the context as we see it today. Thank you.
All right, thank you for that presentation. It was very informative. Let me see if we can. So I encourage people to put their questions in the Q&A. And I will go ahead and start with a question. So what do you think needs, what's the message that needs to be done? What do you think it is that can be data or stories or evidence that can be given to the American public to kind of change that attitude? That sounds like it has already started to change, but continue to change that attitude around refugee resettlement as well as asylum seekers?
You know, that's a great question. And my colleague, the co-director of the Center for Comparative Immigration Studies right here at UCSD, Rita, has been doing some of the cutting edge research on that question, doing survey experiments in the US. And she's found a couple of things which are quite important. The bottom line is that giving people more information, at least about the fact that very few refugees are resettled into the US, as I just said, and that most refugees are in poor and middle income countries, not in Europe and the US and so forth, that does not have an effect on changing public opinion on refugees. There are two things that have at least a short-term effect. One is trying to evoke an empathetic response, i.e. put yourself in the shoes of a refugee, you know, what would you do, that kind of exercise. That seems to have something of an effect. And the other in the US, and this might be particular to the US because most people do have an immigration background in their family, is to invite respondents and people in one-on-one situations to think about their own family immigration history. So, you know, it's a set of findings that sits uneasily with academics who like facts and figures and historical detail, but it does seem that those things that I just mentioned, as well as, you know, narrative storytelling, are probably more effective tropes than bombarding people with presentations like I just gave you.
And how do places kind of become refugee resettlement areas? Like, you know, we think of certain cities, Minneapolis, San Diego, et cetera. How do those places kind of evolve into being somewhere where you tend to get a lot of refugee resettlement?
So most of the agencies that resettle refugees have religious origins, if not, you know, being overtly religious organizations. So my understanding is that's how Minneapolis, for example, became so important in refugee resettlement. It has to do with the large population of Lutherans in that area. So that's part of the story. You know, Vietnamese and other Indo-Chinese coming to the west coast of the US simply because that's where the big military bases were, like Camp Pendleton. And then there's a path dependency story where once refugees are being resettled in a particular place, they typically will be resettled in subsequent generations to that place, or people from different nationalities even to that place, because there's an infrastructure of refugee resettlement agencies there. And I think that's the story of San Diego right now, is that even though there's no particular connection of Syrians to San Diego, for example, when Syrians were being resettled in large for the US scale numbers, small for the world scale numbers, it wasn't because of any particular connection of Syrians to San Diego. It was simply because there are a number of refugee resettlement agencies here, you know, Jewish Family Services, International Rescue Committee, Catholic, et cetera, et cetera. And so they have the capacity to transition people.
Perfect. We have a attendee who has raised their hand, so I'm actually going to try to grant access for them to just ask the question out loud. All right, so I believe to the person who had their hand up, you can probably now speak. Let me unmute you.
Hello.
Hi, sure,
yes,
we can hear you. Go ahead.
Hello, greetings. I'm from Cape Town, South Africa. I heard a presentation from Fitzgerald, and it's very informative. I just want to ask that when we talk about deportation, is deportation not a human rights abuse? When we deport somebody to go to a country that will be persecuted, is it not human rights abuse from that end? Thank you.
Sure. So is deportation inherently an abuse of human rights? You can think about abuse at different levels. In the sense of international law, it is not inherently a human rights abuse to deport someone. It is a human right abuse to deport someone to a country where they would be persecuted on one of the 5 convention grounds. It's also a human rights abuse to deport someone to a country where they would be tortured for any reason under the Convention Against Torture. So legally, those are abuses. Otherwise, deportation itself is not inherently abusive, and in terms of the legality of it. I mean, the conditions of deportation might be such that those could violate human rights law. Now, then you could have another normative debate about if you think that people should be deported or not, that's outside of the existing legal framework. And so then different, people would have different views on that. It's worth remembering that for most of the 19th century, which is when the US received tens of millions of immigrants, there was no deportation statute. It was not on the books, and it was not practiced that the US would deport people for any reason, even if they committed a serious crime in the US. So the massive level of deportations in the US is really a function of policy just in the last 15 years or so.
All right, that was a great question. All right, I don't see any other questions. So Dr. Fitzgerald, thank you so much for attending today and presenting. And we will go ahead now and take a break until 12:20, 12:30. Yeah, so we will resume at 12:30 with the second half of the symposium. Thanks.
Okay, welcome back, everyone. It's 12:30, so we will be resuming. Hello, Dr. Sordas. Okay. So I'd like to introduce Dr. Sordas, our next speaker. Dr. Thomas Sordas is Distinguished Professor in the Department of Anthropology at UC San Diego, where he holds a Dr. James Y. Chan Presidential Chair in Global Health. He serves as founding director of the Global Health Program and director of the UCSD Global Health Institute. His research interests include medical and psychological anthropology, global mental health, and comparative religion. And he has conducted ethnographic research among charismatic Catholics and on Catholic exorcism in the Navajo Nation, on adolescent psychiatric patients and refugee health. His research monographs include The Sacred Self, a cultural phenomenology of charismatic healing, and Troubled in the Land of Enchantment, Adolescent Experience of Psychiatric Treatment, co-authored with Dr. Janice Jenkins. Thank you, Dr. Sordas, for joining us today, and I'll give you the mic.
Thank you, Tala, and thank you also, Gretchen, for the invitation and for including me in this symposium, which I find very enlightening and illuminating. I want to talk today about research that we're currently conducting under the title of Tracing Asylum Seekers' Experience and Trajectory with the acronym TACIT. It's a project of the UC San Diego Global Health Institute and the UC San Diego Center for Global Mental Health. I show here on this introductory slide our wonderful, committed, dedicated, and brilliant research team. And I also want to acknowledge that we have funding from the UC San Diego Academic Senate and the US-Mexico Proyecto de Investigación en Migración y Salud, which allows us to collaborate with our colleagues at El Colegio de la Frontera Norte in Tijuana, particularly including Dr. Olga Ogers, Dr. Olga Olivas and Dr. Yetza Bohorquez. CACIT began or was inspired by the events, the crisis surrounding the caravans that arrived from Central America at our border at the end of 2018. They were inspired by those events, and I have to say, in part, they were inspired by this particular image of a mother and her children trying to go across the border and being subject to tear gas. So the image of tear gas on the border started really our movement toward trying to understand what was going on and make sense of it in terms of ethnography, or writing about the experience in cultural context of people who were coming to the United States in that moment. The goal of our research is to develop an ethnography of care in which we first of all document the evolving network of healthcare for refugees and asylum seekers, and secondly, describe the lived experience of both healthcare providers and asylum seekers. I think it's critical not to leave out the challenges faced by and the experiences faced by people who are providing care, as well as people who are receiving care as they look for a better life. And since March of 2020, we've also been concerned with how this situation has been exacerbated by the coronavirus pandemic. This table or chart describes the different organizations that we have worked with and within which we've interviewed healthcare providers and service care providers. I want to focus today on their experiences rather than the asylum seekers' experiences, because I think that they're often neglected. With respect to the ethnography of care, we've been working along the north-south axis between San Diego and Tijuana, as well as on the east-west axis between California and Texas, trying again to document the evolving networks of care, the kinds of collaborations and the experiences of healthcare providers. We've observed particular challenges with respect to the difficulty in connecting initial medical care with follow-up care in a highly transient population, in coordinating between medical and legal services, in the different circumstances of new asylum seekers and more established refugee communities, and in the circumstances of groups subject to different policy environments, such as migrant protection protocols and post-migrant protection protocols, the evolving policy environment that affects healthcare. So what I want to focus with you on is this part of our research, working with healthcare providers, drawing from our interviews and presenting their experience in their own words. My intent is to provide food for thought about the lived experience of healthcare providers and the consequences of that experience, not only for how professionals adapt and adjust their practice, but also for their own health and well-being. First of all, let's consider the challenge of preparedness for healthcare providers in a humanitarian situation, and the fact that regardless of how well-trained one is, it's not always the case that a person is or can be completely prepared for what one encounters. In the case that we're talking about that began during this migrant caravan moment at the end of 2018, and the development of migrant shelters that Dr. Hill talked about in the first part of the symposium, we had a lot of volunteer physicians, well-trained as physicians, but they were volunteering and coming into a new situation. for this in the situation of well-trained people who were already working with refugees. They were faced with the sudden surge in people that were coming to the border. So let me just point out this issue of preparedness and distinguish between institutional and clinical preparedness. The challenges of institutional preparedness begin with unpredictable increases and decreases in the number of refugees, as well as changes in immigration policies, difficulty in securing adequate staffing, barriers to care in the medical bureaucracy, and lack of adequate communication or communicative channels. The challenges of clinical preparedness include unfamiliarity with rare infectious diseases, complications from pre-existing conditions, mental health effects of trauma and torture of multiple kinds that may be layered one upon the other, sexual and reproductive health of women who flee while pregnant, language barriers when asylum seekers may be arriving from multiple countries, and on the other hand, the over-specialization of clinical volunteers. And I just want to spend a moment elaborating briefly on this, on the last of these challenges. Because again, a lot of people came to volunteer, and in that context, they sometimes didn't feel prepared. So this is part of what we want to attend to with respect to the lived experience of the clinicians themselves. So one said, the previous 15 years I've been working primarily as a clinical and metabolic doc. I did primary care for my patients that had rare diseases, and I was briefly comfortable seeing both kids and adults in that context, but had not worked as a straight pediatrician for a number of years. And this was anxiety provoking. Whether or not I'd be able to make it work, whether I still had the skills and ability to do it. Another volunteer physician said, what am I underprepared for? You know, a lot of times stuff comes up, which is like what you think of as a simple question or routine problem, but I'm not boarded in family practice. I wouldn't know the answer. So every time I go to the shelter, I have to look again at certain protocols because I'd be completely lost without the protocol, even if it's something really simple, like what's the antibiotic for otitis media? I don't know that. I'm not family practice. I don't treat otitis. I have to look it up every time. You see from these brief examples that clinicians are facing some challenges of their own, and these are challenges of feeling prepared, and that directly relates to what I refer to as the lived experience of the clinicians themselves. You know, the term lived experience suddenly in the last year or two seems to be almost everywhere. You hear it on the news media, but in fact, it's a technical term for an analysis that focuses on the immediacy of challenges and immediacy of living in the world and being in the world that people face. In this case, the concept of lived experience becomes very useful for us in answering our question about the ethnography of care. With that as our background, we have, as I mentioned, dealt with the coronavirus pandemic and the adaptations and the challenges faced by clinical caregivers in suddenly having to pivot toward dealing with the coronavirus, in addition to all the other challenges that people face in terms of pregnancy, in terms of infectious diseases, in terms of mental health. And I want to talk briefly about clinics that treat migrants. And I want to talk briefly about the experience of clinicians at the port of entry and at detention centers. Again, we'll benefit from the words of the clinicians themselves. First of all, the UCSD clinic at the Jewish Family Services Migrant Family Shelter that Dr. Hill was talking about earlier. This is an example, or these are photographs from the downtown San Diego facility that they were in for a while. And this is a interview comment from one of the clinicians there near the very beginning of reflecting on things that happened at the beginning of the coronavirus pandemic. She says, yeah, and laughs. And this is important in understanding and relating to and empathizing with the experience of the clinicians. She laughs and says, that was total racism. They were Chinese. They had not been in Wuhan. They hadn't even been in China for over a month, but Border Patrol sent them in N95 masks and scrubs and all their belongings in a garbage bag. It kind of just raised red flags, but then we spoke to them. They'd already been screened for COVID and quarantined. They were totally asymptomatic, so we just realized, and she laughs again, rolling her eyes. This was just purely because they had Chinese passports, but they had actually spent over a month in Mexico before they were detained. They definitely didn't have COVID. And this was when we first just had a few cases in San Diego, and everyone was getting very anxious. This is the Health Frontiers in Tijuana clinic. And one of the clinicians who work there tells us in the early days of the pandemic, this is a UCSD student-run clinic, and the volunteers couldn't come into the clinic at this point. So the scenario here is that the clinician is seeing patients still, but the student volunteers are present only over Zoom. And the doctor says, the other day I was seeing a patient who has psychiatric problems and he had diabetes and other issues. And while I was walking out to look for some medication, the student stayed talking with the patient. Of course, the student had to stay talking with the patient because the student was on screen. And when he came back, he closed the consult, patient left. And then the student told me, doctor, I don't know if I should have told you, but the patient is very religious. He said he believed in God and God would protect him. And he didn't care about getting into crowded places and using a face mask. He knew God was on his side and he was never going to get COVID-19. This is an interesting scenario experientially for the patient, the doctor, and the student. The student observed something about the patient and they were ambiguous and didn't know really how to respond. When the doctor came back, they were able to talk, the student and the doctor, and this turned into a very particular kind of pedagogical moment when the doctor could talk to the student about how to relate to the patient, could talk about the religious aspects of dealing with the pandemic threat on the part of the patient who was themselves challenged with psychiatric problems and diabetes. So the kind of interaction here would not have happened if there wasn't a pandemic circumstance, and wouldn't have happened in the same way if the entire consultation process wasn't constrained by the pandemic and the necessity to operate via Zoom. The Refugee Health Alliance Clinic in Tijuana is another place where we've talked to staff members. And here the response was, the first challenge of COVID was obviously the initial rearrangement of our practice completely. We had to do a 180-degree turn and be like, what is even possible? We knew we didn't want to abandon our patients, but we knew that we couldn't keep providing care the same way that we were. So that meant really going back to our core group of volunteers who could commit to being here. We didn't want to bring in tons of volunteers from all over who could potentially spread disease into Tijuana, And we opened up our new clinic that really wasn't even ready to be opened up, but we were like, whatever, we don't care. We have to respond. Physicians screening asylum seekers at the San Isidro port of entry. Here's a place where there is immediate contact with the authorities, with the Customs and Border Patrol. And the physician's experience here is responding. As a physician in leadership, when you're interacting with Customs and Border Patrol, you do have to maintain some form of relationship with them or everything's lost. Again, note the laugh. And as a physician and a human being, you don't want to turn a blind eye to what your colleagues or advocacy groups, to any of the big tent ideas and say, no, we can't do that. So here's a physician feeling that it has to negotiate between the advocacy groups, the people who are really trying to do everything as possible to help the refugees and the asylum seekers, and the Border Patrol, who have their own constraints and their own ideological biases, perhaps. He says, I get the sense that Border Patrol loves Title 42, the legal authority they're operating under currently because of the public health emergency. And of course, Title 42 allows and requires asylum seekers to be sent back to Mexico without any necessary treatment. He goes on and says that it makes their job that much easier. People get tossed back to Mexico quickly. We don't have all these pesky pregnant women and kids seeking asylum. You know, that's kind of cynical the way I said it, but my observation is that Title 42 is the dream of this administration, the Trump administration, when it comes to immigration for asylum seekers and similar groups of people. The Otay Mesa Detention Center, where asylum seekers were kept against their will, is a privately operated for-profit facility. And we have an account from a clinical psychologist who had been working in and consulting in the detention center. And when the pandemic struck, his response was, the most frustrating part is that I haven't been able to conduct any psychological evaluations or forensic mental health evaluations since April. The US asylum program has essentially closed down and stopped. There's hardly any new referrals coming in. And the good thing is that Otay Mesa Detention Center has released a lot of detainees. They still have some, but the numbers are really under capacity right now. And that's really a good thing because there are less people detained. But it also means for me that I'm not going there anymore and I can't support people through these evaluations because they simply don't have the chance to enter the US and ask for asylum. This, in a kind of lightning tour, are glimpses at the experiences of healthcare providers who had faced not only the crisis of amplified flow of asylum seekers after 2018 caravans, but then had to suddenly adapt to the coronavirus pandemic. During the pandemic, there have been a great deal of moves to, for example, free people from detention centers. As this, you can see on the upper right-hand corner, healthcare providers and physicians are among the advocates. And I want to close with this image, which I think is very striking, from December of 2019. This is actually from Texas, but it's a protest by healthcare providers and physicians who are advocating under the very dangerous pandemic circumstances that asylum seekers who are detained are allowed to leave. So this is the kind of work that we're doing under the rubric of the ethnography of care. the part of it focused on healthcare providers. I see that, I imagine that among our audience here, among the participants, there are people who are healthcare and social service providers for refugees and asylum seekers. And if you happen to be one of those people and are interested in sharing your experience, please contact us, our project coordinator, Alexis Bernstein. We are currently scheduled to end our phase of data collection as of September 15th. So we are in the final phases of talking and interviewing with people. Like I say, if you are interested in being interviewed and you are a healthcare provider for refugees and asylum seekers, please consider contacting us. Thank you.
Thank you so much, Dr. Sortis. This was an amazing talk, very enlightening, and you're shedding light on a very important topic that is usually not given the attention it deserves, which is really healthcare providers and the additional burden that is already on all healthcare providers during the pandemic, but when dealing with this specific patient population. So thank you for all that you do. We have a few questions in the chat. One is, what was the time period or frame for the data collection? So I believe you're still collecting data, but can you tell us, when did you start?
We started conceiving the project at the moment when, as I said before, I saw that first image of the woman with her child fleeing tear gas on the border. That was in November of 2018. And we started assembling our team and getting funding for the research immediately at that point. We started collecting data during 2019. And as I said, our data collection will be complete, or not complete. We have to stop at some point, and we'll stop in September.
Thank you, Dr. Sortis. And I have a question for you. We learned from the pandemic that viruses do not recognize borders. And I was wondering if, you've been collecting data from healthcare providers on both sides of the border, I'd imagine. Could you tell us about lessons to be learned moving forward for, lessons regarding preparedness in general? What are your recommendations from what you're seeing in your research?
At this point, I can't say that we have concrete recommendations. Our job as ethnographers right now is still to document and to put together our interpretation and description and analysis. But one thing I can say is that one important thing is to pay attention to the kind of gaps that exist, that I referred to very briefly at the beginning. There's a lot of work across the border and along the border in trying to elaborate networks, but the healthcare providers themselves, when we collect comments and we collect observations from the different meetings we participate in, there is a gap between medical care that can be provided in the immediate moment and follow-up care. That's a big issue, both for refugees and asylum seekers who stay in the San Diego area, but ones who transit to other parts of the country to get to have any continuity of care is very challenging, and that's something to focus on. The coordination between different types of service, like medical and legal services, is a big challenge that can be focused on, and these are not necessarily coordination of actual services, but just handing off and making connections where connections don't exist or are challenging. We have to also recognize that the different circumstances of the asylum seekers who are flowing through currently and who are transient, and those who are part of more established refugee communities. Their circumstances are different, and there may not be that much communication between those two segments of the refugee population, or among the segments of the service and healthcare providers who deal with those, and again, being sensitive to the changing policy environment. We heard a report. We've all been thinking that migrant protection protocols, MPP, that's terrible. It's got to end, right? And we've heard that it was coming to an end, but we've also then heard reports of people who aren't subject to migrant protection programs saying, gee, we wish we could be under MPP because those people are now, getting through. And there's a kind of sad irony in that kind of situation. So all of these gaps are things I think that I don't have any policy recommendations for how to solve them, but we do have some observations on where attention needs to be focused.
Thank you so much, Dr. Sordas. I'm so glad to see some policymakers also in the audience here from the state level and the county. So I'm so glad you are able to join us, Christine Morto, Farhad Popal, and others. Now we will move on to the next speaker.
Just let me say at the end, I put in, I had our contact information for Tacit on the last slide. I also entered it in the chat just now. So if anyone is interested in that. And again, thank you very much.
Thank you, Dr. Sordas. Now we will move on to Dr. Scott Herskovits, who's a healthcare provider. He is a pediatric emergency medicine specialist and the clinical director of the Department of Emergency Medicine at Rady Children's Hospital in San Diego. He earned his medical degree at the University of Sydney School of Medicine. He completed a residency program in pediatrics at Our Lady of the Lake Children's Hospital in Baton Rouge, LA, followed by a pediatric emergency medicine fellowship at Inova Children's Hospital in Virginia. Dr. Herskovits' clinical and research interests include medical education and simulation medicine. He has participated in international conferences on simulation medicine and its incorporation into medical education. Thank you, Dr. Herskovits, for being with us, and I'll let you start.
Perfect. Thanks for inviting me. I appreciate being here with all these distinguished speakers who I think know much more than I do about some of these situations, but I'm glad that I can kind of share my experience and some of the experiences that we've had here locally in San Diego. So what I'm going to talk about is the experience at the emergency intake site and at the convention center in San Diego that just ended in the beginning of this month. Perfect. So just a little bit of background. I think a lot of people here are familiar with the current immigration situation, the policy challenges. But what I just kind of wanted to go into is that there was a shift in, I think, policy as from the previous administration when compared to the current administration. And this created some immigration challenges that stretched our current facilities, whether that would be the detainment facilities or already established long-term facilities that exist in the United States to help some of the migrant children that have been crossing here. So that being said, as of March 2021, I'm sure as everybody was aware, there was multiple stories in the media, on the news regarding some of the care of migrant children in detainment facilities that was to many absolutely horrendous and not meeting the expectations that they should receive. So at that time in March, there were over 5,000 kids who were in Border Patrol detainment centers at their facilities. There were over 12,000 kids who were under the custody of Health and Human Services. And there were the expectation that with some of these different changes going on at a higher governmental level, that there would be anywhere from 20 to 25,000 further border crossings over the coming months. So in order to deal with this emergency, essentially, what happened was there was the need to bolster facilities in order to take care of children that were coming to the United States. So the San Diego Convention Center, or the Emergency Intake Site, which will go EIS, was an idea that came to fruition very quickly. And we were one of the first sites across the country to be utilized in this capacity. So just a little timeline about this. These very specific dates, as of March 22nd, the local government, as well as some other government agencies, had reached out to Rady Children's Hospital to discuss potentially providing medical services at the local San Diego EIS. Now, the rapidity of which this was actually implemented was amazing, impressive, and also led to some challenges along the way. So by midweek, an agreement was reached between the federal service or federal agencies and the Children's Hospital to create or to serve as the medical service provider for the San Diego EIS. And so that was around, I think, about the 25th or so. And we had just had the homeless, the housing for the homeless in the San Diego Convention Center, that project had just ended. And a lot of those individuals had to be cleared out and placed in other facilities in order to accommodate this new project. And so the San Diego EIS facility was built within about 24 to 48 hours. So I remember going in on March 26th on a Friday morning to the convention center and seeing how the setup was, and there was almost nothing there. However, we had 500 kids approximately that were to arrive for intake on March 27th at some unidentified time. The facility itself was about to have 1,500 children capacity at its max at any given time. And the time frame of this facility was from that March 27th date through July 15th. So we, as being one of the first, there were also other EIS sites that were being set up at the same time to kind of offload the backlog at some of the detainment facilities, as well as to address some of the impending migration issue that was still kind of going on. So for us in our mission at Rady Children's Hospital, as I was kind of saying before, is we were put in place as to provide medical support at the San Diego EIS for these children with an agreement for the Office of Refugee Resettlement, which comes under HHS. I learned way too many federal agencies and alphabet agencies that I didn't want to know about prior to this. So the children that we had at our current facility, which is different from every single site, we had an agreement where the people that we were seeing were girls aged 13 to 17 years of age initially. So as an example, one of the Dallas sites, which was one of the first sites as well, they were seeing only teenage boys. However, as we kind of progressed through this project, there was much more talk of how do we best service these children, not separating them further. And in order to do that, this was more from a federal side, but the siblings of any of these teenage girls who were less than 13 years of age were kept together when they came for transport here. So there were other facilities that saw the teenage siblings that were both a boy and a girl who were teenagers, but that was not our site. we saw predominantly teenage girls, and we also saw younger boys and girls less than 13 when they were siblings. Most of these kids came from Central American countries. I previously had a breakdown of what that looked like, but I actually don't have the data for that at this time. And then most of these families most of the families that they were hoping to be reunited with were in the Southwest, Southeast, and the Northeast of the United States. So I'm going to break down each individual aspect of the services that we provided. So me as the medical director at the site, I had a hand in kind of helping with, I had a lot of help in coordinating the medical services, creating processes, as well as being a clinician in our various aspects at the San Diego EIS. So just a couple things. The first thing was the intake screening. So when kids arrived, there was the need to make sure from an infectious disease standpoint or from just a general wellness standpoint that we are addressing these kids upon arrival and not potentially placing other kids or other kids at an infectious or an infection risk standpoint by mixing or not separating them appropriately, not isolating them appropriately, or not providing medical care that was emergent or urgent at that time. Health assessments that we did, we had a modified health assessment, and these are a little bit different depending on the type of site. Being an EIS site is a little bit different from a licensed facility or from a long-term facility, but these are essentially well child checks. Then within these, identifying special healthcare needs was an integral part of our process. Vaccine administration was integral to make sure that we don't have any infectious disease outbreaks. And then obviously medical treatment on site with our urgent care for any needs that arose. And then because being a local children's hospital, obviously based on the location and where the children's hospital is located, it's very geographically near. So we're able to have that referral to higher level of care. We had our local San Diego County health partners for behavioral health locally as well. And then for anything that was outside of the scope for Rady, we also were able to work with UCSD, predominantly UCSD Hillcrest as well. So just kind of breaking it down on how we went, I would have loved for everybody here to be able to walk through the convention center and actually see the process and understand how impressive it was. Now, that doesn't mean that there weren't issues, because there were a lot along the way. But as we went through, our intake screening, these kids were all brought to us mostly from detainment facilities that were from Texas, some in Arizona, very few from California, to be honest. And they all arrived via plane or via bus transport. And there were sometimes there was communication issues from our federal partners regarding when people would arrive. And that caused certainly some challenges being able to care for them and having some staffing in order for that to occur. But that is something that we got used to during the process, and we're able to kind of just work on and anticipate and be flexible. So all these kids upon arrival, they had health screenings performed. So we created a health screening form for that our partners and our staff would kind of help us administer to every single kid when they arrived. The first night, I will say on March 27th, when we had 500 kids arrive very, very late at night, getting that done was a very fluid process and required quite a bit of refinement as we went on during this project. But it was something that allowed us to kind of collect the data on these health when they arrive. At the same time, most of these health screenings allowed us to kind of separate out really three things. So the first thing being, are these kids coming in symptomatic from an infectious standpoint, and do they need to have COVID testing at that time, or they need to be seen by our urgent care at that time? Both. Or are they asymptomatic and they can simply get their bed placement and go to the dormitories that were created? Additionally, patients who were known COVID patients ahead of time were isolated upon arrival and actually during arrival, as long as they came by bus. And so those people were screened out. We still did see them in case that they needed any kind of immediate or urgent care services at the time. One of the other things that happened was all girls above the age of 10 received urine pregnancy tests upon arrival. One caveat to all this is once kids arrived, we were lucky enough to create a script and have a lot of our ancillary staff who spoke Spanish to give an overview to all these girls, an idea of what was happening to them when they arrived, as well as what was the next step in the process and what they could kind of expect. It was brief. I wouldn't say it was overly comprehensive, but at the same time, a lot of these kids arriving really late at night was problematic in of itself. And then I think there was a lot of fear on what is next and what are they going to do to us at these facilities. So this was something that we had to address immediately upon arrival. Additionally, one of the first things that occurred was we gave prophylactic treatment for scabies and lice, and this was secondary to reports that we had received from some of the other federal intake facilities, from the detainment facilities, that there was anywhere from 20 to 50% lice and scabies rates, and that was secondary to the living conditions at some of those other facilities. However, what we noticed and what we were able to do is use a data-driven process, thankfully due to our EHR, which we had a special agreement with our federal partners to use to actually determine as the project went along, how many kids actually had lice, how many kids actually had scabies. So then this helped us to inform our processes and update that to where we become more of an episodic approach and incorporated in our screening questionnaire questions about symptoms for scabies and lice to then check immediately upon arrival whether we needed to treat at that time or whether we didn't. COVID screening, obviously, during the time of this pandemic was very important as well. So just to kind of go through the process, our the Border Patrol facilities or the detainment facilities, they were providing antigen screening for all children that were transferred to EIS site. That testing was supposedly done day of transfer, and there was sometimes a lack of concrete physical information that we received, whether people were negative. It was a kind of went on trust to an extent for a while that they were testing negative, but this kind of fed into our screening process to double check that, because obviously with the detainment facilities and with Border Patrol, they are not medical professionals. You know, we don't expect them to potentially even do a nasal swab appropriately. And I think that's helped us inform the process that we had to do, but those things did occur. So once these kids did arrive, if they were symptomatic, they would receive rapid PCR testing that we had set up within our EIS site. And the turnaround for that was about 20 minutes. So what we could do is actually, I quarantined some of these girls initially, have that done very rapidly to determine whether they needed true isolation for COVID or they needed to rather just go into a warm pod for those who were symptomatic and it could have been some other infectious disease, but to kind of separate out some of these kids. Additionally, we had screening twice weekly for COVID, essentially asymptomatic screening that the kids, based on where they were as far as their beds were concerned, they had that screening done, and then symptomatic testing, obviously, when indicated. So just a little data from our site. So out of all the screening that we did, we had over 20,000 COVID tests performed and about 500, a little over 500 that were positive from the children. And then staff, you can see we were also had a mandate that we had from discussions with CDC, as well as local San Diego Public Health, as well as our infectious disease. And we were screening voluntarily workers at the convention center weekly. And you can see what the numbers were there. Our numbers were initially higher than the general population at the time. They did decrease, but there were certainly fluctuations in our positivity rate really related to our intakes. So as we received a lot of these new patients, There were definitely patients that were missed from their initial screening prior to transfer from their from the detainment facilities. And so these kind of contributed to those increased numbers. We had less new cases from kids who had already been there for any period of time. There were certainly, from a public health standpoint, cases where kids received, got COVID from outside. So that was a possibility and was sometimes hard to track. Just a couple things, the health assessments. So I do want to leave some time for questions, so I'll get through this relatively quickly. What we had was we did essentially these well-child checks within 48 hours of arrival. And in these health screenings done by mostly pediatricians, some family practitioners, some other providers, what essentially was kind of trying to identify these acute and chronic conditions and then be able to document those within our EHR, be able to refer as needed for outpatient services and provide that data to families, as well as help arrange to have that outpatient care once they were reunited. And then if they needed it during their stay at the EIS, we could arrange that as well. And then also providing prescriptions. We had an on-site pharmacy, as well as couriering other medications that were not at our pharmacy for some of these kids. And then one of the things that we also did is we would discuss the urine pregnancy test for all the children who we tested for, and we had to actually, in coordination with legal that was there, we were able to kind of craft a statement that reflected the legal guidelines on their rights and provided that to them in their native language so that they were aware of what their rights were if they were pregnant and how that would affect or not affect them. So as you see, we did over 3,000 health assessments and identified over 250 special healthcare needs. One of the other things that we did, which was massive, was our vaccine administration. So I have some of the data there as well as the schedule. And from a public health perspective, the biggest thing that we had kind of figured out or that we determined was the most important vaccines initially were MMR and varicella, because outbreaks amongst populations in close-knit quarters like this, even with spacing, even with masking, was something that we wanted to prevent. And those were the two biggest vaccines that would help outside of potentially COVID. We expanded to Tdap, DTaP, flu, and Hep A. Flu and Hep A was an expansion secondary to some cases being reported at Texas facilities. These were coming from likely Southern Hemisphere sources. So our flu vaccine was from the previous year. If it would have had any benefit, there was discussion. It certainly wouldn't hurt, but the likelihood it was benefit was marginal. Hep A, there was a few reported cases at one of the Texas facilities, so we added that. COVID vaccination was always something that was on our minds, having discussions with our federal partners, and this actually was implemented later on in the project, so in June. So there was some things that prevented that, where the vaccine was not approved for the ages that we were seeing initially, and the vaccine was not even available to our current San Diego residents and kids to have that first. So once it became more readily available and once it was approved, we were able to roll out a COVID vaccine process. And we actually had an insanely high success rate. So we actually had a 99% compliance rate for COVID vaccination with the children that came or that were at the facility at the time. So you see, we had about 500 kids vaccinated. And one thing that we did notice, just anecdotally, some of the concerns that came up with the COVID vaccination was pregnancy related. So a lot of girls were actually fearful that this could affect them becoming pregnant. It could affect them having children in the future, how it could affect their children in the future. And so that was something that we had to address. We created a script and provided assent for them, had medical legal discussions at very high levels to make sure that these girls were being able to be informed, getting informed consent, and providing assent for these vaccinations as well. Our urgent care was staffed 24/7. We had over 5,000 urgent care encounters. We treated various things, multiple different infections, a few varicella outbreaks. We actually had about, I think, 3 cases in total and prevented multiple others. quite a few behavioral health emergencies, a few surgical emergencies, and various orthopedic injuries as the kids were able to get to doing more normal kid things, whether playing soccer, riding bikes. And we had about 100 ED visits, so transferring to higher level of care, mostly for GI, GU concerns, and a couple MSK related issues. So just kind of the living conditions. If you can kind of see on the right, most people have seen these. This was kind of at some of the detainment facilities, which were not ideal to say the least. And at our EIS, while I think being reunified with family would have been the best situation for most of these kids, the facilities were actually relatively reasonable. They were separated from an infectious disease standpoint. All these kids had their own place to sleep on, and they were able to kind of make friends with those within their areas. And it was a nice facility to be at. Some of the ancillary services that were provided as well. We had the San Diego union teachers who came in and actually had developed a curriculum for providing classes for these kids. There was legal representation that they received daily. The San Diego Dental Association came in and provided care. We would refer them to the Dental Association, identify those who needed care, and that would get performed. Same thing for optometry services. And some of our great partners was our San Ysidro Health, because behavioral health was definitely a pretty significant concern in the beginning. Obviously, many of these kids have gone through pretty significant traumatic experiences, and addressing some of those issues, whether through counseling sessions, individual sessions, was of the utmost importance. And then there was also kind of educating staff on how do we de-escalate certain episodes that occurred. There were thousands and thousands of phone calls made, and some of the dormitory partners, case managers with South Bay Community Services, were incredibly helpful to kind of coordinate their everyday life with the medical services that needed to be provided. So just some of the quick activities that were performed. They got to go to surf camp in Imperial Beach. They had SeaWorld animal shows that came in, and even kids who were in isolation, they kind of created barriers and allowed them to see. They went to see the San Diego Loyal, the pro soccer team here. They had concerts, and I'm going to play this very, very quickly. It was just very nice to hear all these kids kind of singing along at night for a concert. All right, I could go on with that. And then just a couple lessons learned as we're short on time. So there was a lot of cultural dietary differences that we noticed as we went on. Two of the most prominent things were actually pork and pineapple, and that was causing quite a bit of GI discomfort. And so we had to have multiple conversations with federal dietitians that were on site, as well as the culinary services, to kind of adjust the food menu to have a more representative diet, something that would be more tolerated. And then there were significant behavioral health challenges. That is a whole nother topic in of itself. Infectious disease compliance, whether that's masking with the kids, whether that's testing and masking with our staff, was an issue. And then I think one of the other things that goes missed sometimes is the importance of identifying the indigenous languages. So we had quite a few that were there. A lot of these kids did speak Spanish, but their Spanish was minimal. And when you talk to them in Spanish, you would get the sense that they did not understand what you were saying. So identifying that early to help them is something that was key. And so this is just my last slide. So we as in the partners kind of reunified over 2,200 kids, which is about 75% of kids were reunified that came through the facility. The others went to more long-term facilities as they're working on reunification. And you can see that the average time was about 42 days. And I can go to the actual site here. So if you can see this, this map is kind of a cool representation of where all these kids went throughout the United States. And that's it. So if anybody has any questions, I'm happy to answer them.
Thank you so much, Dr. Herskovits. That was amazing. We have a question here. What were the protocols should a minor be pregnant?
So I will say some of these things that I can talk about. Some of these things I can't talk about simply because we had a non-disclosure agreement that was signed, that we all had to sign from the federal government. However, the process I can certainly talk through. So we would identify those who were pregnant, and during our health assessments. During those health assessments, the kids would be told their rights, their legal rights on what they would do. So they were kind of read a Garza statement that kind of identified what that meant for them, and then had the medical discussion about what they wanted to do, what questions they have, and how we can help them provide that care. And so once it was identified what their desire was regarding their pregnancy, we were then able to work with our other partners there at South Bay Community Services to arrange outpatient care, because Rady in of itself, we actually don't have OB-GYN, we don't have those abilities. So we had to partner or use some of the outpatient resources that we had, whether that be Planned Parenthood, which also has a relationship with UCSD, to facilitate anything that was needed. Otherwise, we could provide and arrange care for any routine care for the pregnancy as well. And sometimes we did have a protocol in place if any of these pregnancies were secondary to sexual assault. We actually had a nice flow sheet that was created in order to do more expansive testing on these girls to make sure that there wasn't any infectious disease issues that we needed to address. And even without those, as far as the trauma-informed counseling, we had that ability at the convention center as well, which was a fantastic component to have.
Perfect. Building off of that note, there was a question on, were there kids with physical or mental impairments, and how were you dealing with that, disabilities mentally or physically?
So we did. I will say it was a smaller amount. However, we did have quite a few kids who had autism or autism spectrum disorders. We had a few kids who had some intellectual disability secondary to trisomy 21. And most of those, so I think, to be honest with you, we were lucky that some of those were accompanied by siblings. So that was a benefit that I think we were afforded, and we had the ability to kind of work with the sibling who knew their obviously who they were with, and so we could provide care that was needed from that standpoint and involve them. I know we're involving a teenager, but they know these kids, or they know their siblings best, and to be honest, they, for better or for worse, the amount of stress that they've been through, they're like adults. And they have so much responsibility that they've taken on that they are able and they're willing to help us kind of coordinate what's needed from their kids.
That's great. Thank you so much. Thank you for stepping up to this in a short time frame since March. Thank you for all what you do. Kids are kids. Thank you for letting them play and letting them be kids. So we appreciate everything that you do. Thank you. Now we'll proceed to the next speaker, Rama Awad, who is a community partner with us, which we're very excited to have. Rama is a San Diego-based community organizer and advocate. She graduated from Stanford University in 2017, where her studies in community-based research focused on the rights and resiliency of refugee communities. Rama currently works with the Majda Center, a local resource and community center based in El Cajon, for San Diego's Arab residents, refugees, and immigrants. The center works on youth empowerment, community health and well-being, and advocacy, and is one of 11 organizational members of the San Diego Refugee Community Coalition. Rama, it's great to have you with us.
Hi, Tala. Hi, everyone. Thank you for having me. I'll go ahead and share my screen. I have a PowerPoint prepared. Great. Okay. Thank you again, Tala, for the introduction. Again, my name is Rama Awad. I'm the programs manager at the Majdal Center. A little bit about the Majdal Center. We are a resource and community center for Arab refugees, immigrants, and residents in San Diego. We're based in El Cajon, so we are in East County, but our community base spans across San Diego County, and we work primarily with the Syrian, Iraqi, and Palestinian communities, the majority of whom are newly resettled refugees or newer immigrants to San Diego. As Tala mentioned, our main areas of work are the following, and they all intersect. So these are our 4 key areas of work. We work on youth education and leadership. We work on community health and well-being, newcomer support, and advocacy and policy. Also, the Majdal Center is one of 11 ethnic community-based organizations. The Office of Refugee Resettlement defines an ECBO as a nonprofit organization that was founded and is led by a current or former refugee or a group of current and former refugees and immigrants, primarily for the advancement of refugees. So that's the official definition. And the coalition was founded in 2019 with the mission to lead coordinated action to ensure that individuals and families from refugee communities throughout San Diego County are healthy, safe, and thriving. And it's actually being anchored by the UCSD Refugee Health Unit. And this is where a lot of our work, specifically our community health work as an organization, takes place. It's through this coalition. And so today what I'll be mainly focusing on is the coalition's work and one of its reports that it published back in September 2019 on the impact of the pandemic on refugee communities in San Diego. So while I work primarily with an Arabic-speaking population, I think it's really important to zoom out and look at the ways that the pandemic impacted refugee communities writ large, and where relevant, I'll speak to the specific issues that my community has been facing in East County. So just for some context, and maybe this was covered earlier today, but San Diego has a really long history of receiving resettled refugees. Between 2009 and 2017, San Diego received 40% of the total 50,000 refugees that were resettled to California. So this is a really substantial percentage for one single county to be receiving. And then since 2000, 80% of the refugees resettled here come from Afghanistan, Burma, the DRC, Eritrea, Ethiopia, Haiti, Somalia, Sudan, Iraq, and Syria. So again, my community base is Iraq and Syria, but if we zoom out, and what I'll be speaking to today is that a lot of the challenges faced by different refugee communities are related and very similar in terms of their experiences. So as I mentioned, I'll be focusing on these 3 points. So really looking at the impact of the pandemic and what that told us about, and what it continues to tell us about pre-existing challenges with healthcare that were worsened by the pandemic, looking at how the pandemic actually magnified different social determinants of health inequities, and then lastly, how the pandemic propelled models for collaborative solutions. And so the reason that I'm focusing on the pandemic is because it really put a microscope on the challenges that our communities have been facing for a very long time now. And we're also going to be dealing with the aftermath of the pandemic for many years to come, because our communities were some of the most hardest hit in San Diego County. And so to do this, I'm going to be mainly looking at the findings of our report, which we as a coalition conducted through interviews. So this is published. It's titled the COVID-19 Refugee Community Impact Report. It was as I mentioned, published in September 2020. We surveyed 306 refugee families from 18 countries, from Africa, the Middle East, Central and South Asia, and the Caribbean. Most of the families that were surveyed live in Central County or East County. And so these surveys were conducted through phone calls or in person by our community health workers. And I'll also be talking about that later on. So the report itself focuses on these key areas of impact, which also overlap with social determinants of health. So we have an assessment of health access and physical and emotional well-being. We have findings about employment, income, and basic needs, how the pandemic impacted those, how the pandemic impacted housing stability, education and youth development, and then social connections, either through different social networks or religious networks, and then as well as resiliency and the connection to social networks. So starting with my first point, looking at how the pandemic worsened pre-existing challenges with health access. The pandemic really did put a spotlight on public health, nationally speaking, and it also garnered more scrutiny in terms of our marginalized communities' access to health. And more generally, our healthcare system and the shortcomings when faced with a severe public health crisis. So with the healthcare system overwhelmed by the pandemic, combined with a shift to different forms or methods of telehealth, this made health access really difficult where our communities were already struggling in accessing health. So some of these barriers include language barriers, as well as comfortability, trust with healthcare providers, or there being a lack of cultural understanding or religious understanding of where these communities are coming from. This could also be related to costs of insurance or copay. So this ties back to economic stability, which I'll speak to more. Transportation limitations, so wanting to access healthcare providers in person, but not having the transportation to get there. On the flip side of that, when things shifted to virtual healthcare, that also posed a lot of challenges to our communities who don't have stable internet connection, adequate electronic devices, and as well as digital literacy, or not knowing how to navigate different technological platforms. So the pandemic really compounded a lot of these existing challenges. The last point being navigating complex systems of care. As a young person who was born here in California, I myself have had a lot of challenges navigating the healthcare system. So we can imagine that for a refugee family that's resettled here 2 years ago, or even within the last few months, that they're facing even a harder time navigating insurance, navigating different healthcare providers, and so on. So these are some of the statistics from the report. So everything that I'm sharing today is found in the report itself. The primary languages spoken at home of the families we surveyed is Arabic. So about 61 families primarily speak Arabic. Here we have a summary of the barriers to healthcare. So here we have at 88%, combining so some families indicated these are major barriers to healthcare, others were minor, but in some, that's the total percentage of these different barriers. So concerns of being exposed to COVID-19, should a family enter a hospital, the medical system being confusing, language, not having adequate interpretation or translation services, and so on. So the next point that I want to look into more is how the pandemic magnified different social determinants of health inequities. So as community advocates and as health workers, we don't view medical health or physical health in isolation from different environmental, economic, and social factors. So these social determinants of health inequities also came into focus with the pandemic. So in terms of economic stability, the report concluded that almost 75% of families reported some sort of loss of income due to the pandemic. 59% of families expressed extreme concern about employment and income. And here it's really important to note that before the pandemic, refugee communities were more likely to be low income, unemployed, or underemployed, and struggling to meet day-to-day needs. Refugee employment is also heavily concentrated in the service sector. So here we're talking about transportation services, hospitality, retail, food. And so these were some of the hardest hit sectors from the onset of the pandemic. So really, a lot of our communities were struggling with economic stability, and this kind of dominoed into other areas of life. So it affected food security, it affected housing stability, it affected levels of stress and anxiety. And so it was really taking a toll on our community's mental and emotional health. In terms of food security specifically, 70% of families indicated concern about access to food. And the findings also showed that the more recent arrivals coming from Haiti, Afghanistan, Syria, and Iraq, so Syria and Iraq being the majority of the communities I work with directly, the report showed that they are more likely to be concerned with access to food. And this is because a lot of our infrastructure as community organizations working with these populations were not yet at capacity to be handling food distribution. Whereas some of the already established refugee communities with larger ethnic community-based organizations have been able to step in more effectively and provide food and deal with food insecurity more directly. Housing stability. So this was one of the biggest things that we dealt with from the beginning of the pandemic. But again, the pandemic really exacerbated existing housing inequities. So prior to the pandemic, affordable housing was a major barrier for our communities. But since the pandemic, 60% of families, and I'll turn to the slide. Yeah, 60% of families were not able to pay full rent and owe money. So in this case, what happened is that we began playing the role of helping community members apply for different rental assistance programs, either from the county or from other larger nonprofit organizations who could hand out rental assistance. But again, these are short-term solutions because at the start and end of every month, we see the same families still struggling to pay a backlog of rent and afford the next month's rent. So housing was a really big issue for the communities that we work with. On education and youth development. So this was, since the center that I work at was founded in 2018, our primary work was for youth, around youth leadership, education, and empowerment. And so when the pandemic started, we realized that our students were going to be affected the most because a lot of them are classified as English as second language learners or ESL learners. And so where they were already falling behind academically, with remote learning, they were faced with even more challenges in terms of access to internet, a quiet place to study, keeping up with their homework, being able to access their teachers and access academic support. So here is an example of how we stepped in and we tried to offer online tutoring for our students. But again, the pandemic really did worsen that, the situation for our students. It also contributed to a sense of isolation, not just for the youth and our students, but for the families. And this had a huge toll on the mental and emotional health of our communities. So different stressors that existed were made worse by the pandemic. And this was shown in the report in terms of increased levels of anxiety, feelings of isolation, reduction in physical exercise, as well as problems with sleeping and eating due to the stress of having to make ends meet for rent or ensuring that your kids have access to their classwork and their classes. So this is another graph that's included in the report. And I think the highest indicator was about a third of the families that we surveyed indicated challenges with remote learning due to the pandemic. So lastly, I'd like to talk about how the pandemic propelled models for collaborative solutions. So I realized that a lot of my presentation was more speaking to the challenges that we've been facing, but out of any crisis, I believe that our communities also develop the resiliency towards inventing new solutions. And so I saw this most clearly with the San Diego Refugee Communities Coalition. Starting with the report, this was a form of community-based research where we as community advocates working in our communities have that relationship and have that trust built, so that when we're asking them questions such as those included in the survey about how they're doing, how their physical health is, how their emotional health is, we're able to get more genuine answers because of the relationships we've been building for many years. So I think this is something to note in terms of the strength of community-based research. The SDRCC has also been a leading model in how different nonprofits and particularly refugee communities can be working collaboratively and in a cooperative way, as contrasted with what we often see in the nonprofit space is competition over resources. It's not unknown that our communities have been under-resourced systematically, and our community spaces, our community institutions are also highly under-resourced. So there's so much power in uniting our efforts and actually applying to grants together, serving as lead fiscal sponsors on grants and having other organizations then subcontract to the fiscal lead. So we're seeing a really powerful way of how do we share resources when it comes to grants as a way to strengthen our refugee communities across the region. Our work with the Refugee Coalition also increased our capacity. So as a whole, we were able to hire 20 community health workers. I think that number has since increased through the County of San Diego. So we have been able to grow our capacity to disseminate information about the pandemic, to help family members sign up for their vaccine appointments, and just be a point of contact for our communities and be able to bridge information coming from the county or the state to our refugee communities. So in total, our 20 community health workers speak about 21 different languages. And so we're able to reach a majority of refugee communities through this newly established workforce. Since April of this year, we were able to hire community support navigators who serve as counselors with individuals and families to help them navigate whatever issues they're facing. So if a family needs help finding rental assistance, the community support navigator that we have on staff is their first line of contact. If someone's seeking mediation for a dispute with the landlord, we also help refer them to other organizations that specialize in that sort of legal advocacy. So this has been really important for us as a community-based organization to have staff dedicated to counseling families through the pandemic as well as the aftermath of the last year. And lastly, the report also includes calls to action. So this is a couple page a couple pages towards the end, but I'll just focus on one area, being health access and physical and emotional well-being. The report outlines current efforts, immediate needs and requests, as well as long-term investments to support system change. So these are outlined per area of impact that I spoke to before, but looking specifically at this area of impact, again, this was from September of last year, so we've since come a long way with the hiring of community support navigators, but I do think that a lot of this still stands in terms of what can the larger region be doing to really alleviate some of the impacts and challenges of the pandemic, and not just the pandemic, but the healthcare system more largely. So we have here what we've done and what we continue to do is grow our community health worker capacity. Ideally, these are sustained through the county or other forms of funding so that even beyond the pandemic, we can continue to be community health resources to refugees here. And then since the coalition is anchored by the UCSD Refugee Health Unit, I think long-term, we are looking for more support in that way to serve as a backbone to grow the capacity of the entire coalition, and in turn, grow the capacity of each member organization as well as refugee communities. So with that, I will conclude and take some questions. Thank you for giving me the time to share. I've linked some of the reports here. I just want to highlight another report published every 2 years by PANA, the Partnership for the Advancement of New Americans. So it's linked here. And then I'll also leave my contact information for any follow-up. Thank you.
Thank you so much, Rama. This was very informative. Thank you for all the work that you do. It's very inspiring. I think you guys are setting a great example for community partners that are willing to use scientific data for the greater good and for social justice issues. So thank you for all that you do. I am monitoring the chat. Please put in your questions if you have any. We have one here. Thank you, Rama, for this informative presentation. Does Majdal have Arabic-speaking mental health counselors available to the refugees in El Cajon? And if so, are they clinical social workers or psychologists?
Thank you. So we are a younger organization. So I mentioned that we have been around since 2018, but actually didn't start hiring staff until last year. And so that's definitely a goal of ours. We'd love to have in-house mental health services, but currently we do it based on referral to other mental health organizations. So for example, Licensed Freedom is another local organization right across the street from us, and we have a really good partnership with them, also through the Refugee Communities Coalition, but oftentimes we'll just refer community members to them because they have the entire, they have staff dedicated to that. Currently we have, as I mentioned, we have a community support navigator, and then we have 2 community health workers and myself. So these are our current staff, and that's what we've been able to sustain so far. But we would definitely like to be hiring someone dedicated to that, as well as providing our staff with mental health resources directly, because we are dealing with very delicate and sensitive issues, and we should recognize that that kind of social work does take a toll on staff directly. So we're definitely in need of those types of resources.
Thank you, Rama. Another question, with medical care, do you recommend any particular format for translation? So family members versus community agency, advocate versus available translation services, etc. This person works in dental care and wonders what is most successful.
Great, thank you. So I think that's a great question. A lot of times what I've seen is that clinics don't have Arabic speaking staff or always available interpreters. And so I think what happens is that a lot of times we're called in to do translation and interpretation. But I really think that, especially in East County, where there's a huge concentration of Arabic-speaking refugees, I think it's really important for clinics to have on staff Arabic-speaking doctors or dentists, or even the front desk, to have someone who is Arabic speaking, and this way it's built into our healthcare system and it's less outsourced. I think when we begin to outsource translation and interpretation services is where I've seen the most confusion or the most inconvenience or just challenges when institutions need to be outsourcing those sorts of services. So I think as much as we can, pushing for the healthcare industry to be hiring from the community even. A lot of our community members were doctors in their homelands or were healthcare professionals in their homelands. So I think we also need to be advocating for them to be given those same opportunities here.
Great. I have one last question for you, Rama. So Rama, working with different community-based organizations, ethnic community-based organizations, what are the challenges with, working with another ECBO that deals with another refugee population with maybe different health challenges or different even experiences before moving to the United States? What are the challenges and where are the opportunities?
I would say that the challenges for us is that, while a lot of the refugee communities across the county face the same challenges, I do think it's important that we also recognize the different, the particular challenges faced by different ethnic groups, different religious groups, different national backgrounds. So there are nuances in the refugee community, and I don't want this to generalize the refugee communities that we work with, but I think within those different, different identifiers, that there are different needs. And so I think it's never going to be a one-time fix or a blanket solution, but the best we can is to unite under this banner of we are all, or we work with refugee communities that more or less face similar challenges as newcomers to San Diego. And a lot of that, at the end of the day, connects back to economic stability and socioeconomic status. And I think that's one of the uniting factors as community centers that work with a largely working class population. That's, I think, something that is an issue that we want to work towards as a coalition, because we recognize that rental assistance, short-term food distribution, even government assistance and subsidies, these are not long-term solutions. So how can we be, and this is an opportunity, how can we be advocating for those long-term changes in terms of employment, in terms of access to education, and so on.
That's great. That's perfect to see, Rama. And I wish, we have a lot of audience also from different places and parts of the world, from different states here. So I think there's a lot to digest and learn from your talk. Thank you, Rama. Now we will move on to the next speaker, Dr. Altaf Saadi, who is a general neurologist and health services researcher at Massachusetts General Hospital and Harvard Medical School. Her research focuses on neurologic and neuropsychiatric health disparities and addressing the needs of displaced populations, including immigrants, refugees, and asylum seekers, both within the community and in immigration detention. She serves as the Associate Director of the MGH Asylum Clinic, a medical expert for Physicians for Human Rights, and a faculty affiliate for the MGH Morgan Institute and the MGH Center for Law, Brain, and Behavior. She's a graduate of Yale College, Harvard Medical School, and the UCLA Fielding School of Public Health, where she received her MS in Health Policy and Management. She was named a 2020 Stat Wonderkind, a 2021 National Minority Quality Forum 40 Under 40 Leaders in Minority Health, and she's also the recipient of the 2021 YW Boston Academy of Women Achievers, Sylvia Farrell-Johns Award for a rising professional woman of color who is a leader in her field and Changing Boston. Dr. Sadi, thank you so much for joining us today from Boston, and I'll give you the mic now.
Thank you so much for the introduction, and I'm so excited to be here to get to talk about a topic that I am so passionate about, that is near and dear to my heart, which is the neuropsychiatric health of refugees and other displaced populations. I hope that you'll go away with sort of two main takeaways beyond just specific numbers around particular diagnoses in this population, and that is one, that neurologic and psychiatric issues really go hand in hand, and we need to think about them as being interlinked. Where the disproportionate focus has been on psychiatric issues, we really need to be thinking at how those combine with neurologic issues, and where we may be missing that. And then the second is really to take the approach of assuming universality with regards to trauma, and to do universal screening with some of the neurologic conditions or exposures that increase risk that I'll be talking about. So these are my disclosures in terms of financial disclosures, but personally to say that I am an immigrant myself and became a citizen in the United States in 2016. And so this work is both personal and professionally important to me. I wanted, again, really trying to think about broad frameworks that influence how I approach this work, is thinking about trauma across a continuum of experience. This is what's often called the cumulative stress theory, where people are exposed to multiple and repeated traumas over the course of their life, and that influences their risks and both biologically and psychologically. So this is from a paper that colleagues and I did that really focused and wanted to integrate the detention experience as part of the larger migration journey. But I won't go into a lot of detail because other speakers have already mentioned this, but thinking about the pre-migratory trauma, the migration journey, and oftentimes we end up seeing them in the community. These are things where factors that have already been discussed, like poverty or housing or restricted employment opportunities, play a role. But I sort of show this model really to just hit home the point that there is often a lot of trauma that precedes what we end up seeing. And I think this also influences even the nomenclature that we often use, right? So in the community, people will have had the label refugee attached to them, but their pre-migration experience or their migration journey itself, they might not have had that label attached to them yet, right? So in order for someone to become a refugee, they must have interfaced with either the UN or some other agency that sort of gave them that label, but beforehand they may have been asylum seekers. For some people, they have been undocumented in whether here or other parts of the world. And so we get to sort of see them in this one particular context, but there are these other slices that influence their health and neuropsychiatric health risk. So I'm going to go through this continuum of experiences and talk about some of the issues that I have seen as a neurologist, and sort of how that intersects with psychiatric issues. So in terms of war-related traumas, oftentimes, this related to gunshot wounds or shrapnel wounds that can result in head injury or peripheral nerve injury. When we think about people fleeing persecution, that can be in the context of gang violence or intimate partner violence or police violence. Oftentimes, traumatic brain injury is significantly under-detected in this population. But oftentimes people will just describe, I was beaten all over. But if you sort of specifically ask, were you choked or strangulated, or were you hit in the head? That can, having had, whether it's traumatic brain injury from being hit in the head, or oxygen deprivation from being strangulated, or potentially having a near drowning experience, that also has implications in terms of their brain health. And so it's important to ask about that. And then torture sort of being a significant part of the story. I know there have been studies that have estimated that the torture experiences ranges anywhere from 5% to 35% in refugee populations. But there have been studies that show people who are subject to torture are more likely to have neurologic issues. And obviously that goes hand in hand with psychiatric issues because these experiences are very psychologically traumatic. Just to give you a context of some of, this is from a paper titled Torture and its Neurologic Sequelae. And just to kind of give you a sense of the various things that we see, obviously blunt trauma, so just being hit, is by far the most common. And I think an important thing to keep in mind in the context of torture is that the implicit aim of someone who's carrying out the torture is to avoid leaving marks and to avoid leaving permanent physical marks. And we're often seeing them many years later, and so they don't have physical marks. And so just because it's not something that's obvious that it might be obvious to us in clinic, doesn't mean that they might not have been exposed to that. And so it's important to ask. I already mentioned about asphyxiation or strangulation. Again, I think that's a really under discussed and recognized phenomenon in the context of head injury. But when you ask particular people who were imprisoned, is something that can be commonly experienced. And then even from different suspension positions or restraint, this picture here sort of shows someone who might have been in a particular position, but that can cause injuries to different peripheral nerves or in their feet. And so people can have, numbness, tingling in their hands or feet where limitation in function, but that is important in the context of this exposure that they've had. This other picture that I have here of someone's feet is a consequence of, just even being beaten in the foot, which is a common form of torture that can lead to people to have peripheral neuropathy much earlier in their life, have difficulty walking. But again, they might have concurrent potentially diabetes, or someone might think, oh, well, they're anxious and depressed, and all of those might be true. But on top of that, they may have had these experiences with the sequelae that I think is important for us to think about and ask about. I think these are some studies that I wanted to highlight. Here on the left is a sample of 200 some refugees in the context of the Syrian war. And they were looking at neurologic injuries, and what was most common by far, over 90%, was peripheral nerve injuries. So more, and then followed by less than 10% spinal cord injury or traumatic brain injury. And I think that's oftentimes we don't think about that because people come, well, they'll just have a little bit of tingling in their hands, or may not have functioning as well, but as a result of this. Oftentimes from, again, gunshot wounds or shrapnel wounds. I think one of the things that the study highlights for me is really thinking about survival bias and how that impacts what we see in terms of neurologic illness in this community, right? So in this particular study, traumatic brain injury was less than 1%, but these are people who had been in the hospital, and doesn't take into account that people may have died from really severe head injury or very severe spinal cord injury. And a lot of, again, that these studies, because they focus on sort of refugees who may have been in the community for a while or in refugee camps, really miss some of the more severe neurologic illness that might actually be significant in terms of the care for this population in the acute settings that we miss by sort of focusing on people later in the spectrum of the migration journey. This paper on the right, focusing on Iraqi refugees in refugee camps. And here the three most common neurologic issues. One was back pain, two was headache, and the third was epilepsy. And in the study that they found that those who were subject to torture were more likely to have neurologic diagnoses. And even just with those 3 diagnoses, I think for those of you who may be clinicians, you can really think about how having psychiatric illness can impede recovery from those issues, right? So people who have really bad headaches and they have concurrent depression or anxiety, the headaches become a lot harder to control in terms of recovery. And really needing to think about these 2 things together in order to treat the person holistically. This is a study that just looks at some neurotrauma during the migration journey. Here they document spinal cord injury and head injury just in terms of border wall jumping in the US-Mexico border. Again, these folks don't have the label of refugees, but many of them may have been asylum seekers and we don't know. And I think I just sort of illustrated this to hit home the point that there is a lot of neurotrauma that occurs well before they show up in our clinical spaces or in our community-based organizations, and we might be under capturing them because we're not attaching the label, refugee at that particular point in their migration journey. And then in terms of post-migratory trauma, we know that whether it's exposure to hazardous working conditions or neighborhoods that are not as safe, all of those increasing risk of like concussions or head injury, and how social determinants of health in terms of the neighborhood context can influence how they heal or recover from various issues. I won't go into this much because I think previous speakers have really emphasized this. I did want to highlight 2 studies that are really focused on refugees in the resettlement context that emphasizes how these neurologic and psychiatric issues go hand in hand. So this study here is based in Germany, looked at about 100 refugees who presented to the emergency department and compared them to a matched non-refugee cohort. And they found that the most common presenting symptom to the neurologic symptom to the emergency department was seizure-like movements. But what they left with in terms of diagnosis after workup was that these were actually more often to be psychogenic, non-epileptiform seizures, which may have been missed, right? Let's say if someone had sought care out in a refugee camp or in a different context where they might not have had access to diagnostic testing, but are in the resettlement context may find that the seizure-like activity was non-epileptiform, meaning not originating because of abnormal brain activity, but because of how the body sort of manifesting the psychological trauma. This study looked at head injury and neuropsychiatric issues in asylum seekers in the US. This is approximately 200 some asylum seekers whose medical affidavits were reviewed, and almost 50%, around 42.5%, had some sort of head injury, 43% reported headache, and about a third reported having some sort of memory or cognitive issues, which I think traditionally people have attributed to the psychological trauma, but given how prevalent we see head injury is, that could also be contributing. And in the study that they found that people who had head injury were much more likely to have headaches and depression. So again, emphasizing how often these 2 neurologic issues and psychiatric issues really go hand in hand. And we know, for example, with head injury, that if someone has depression, PTSD, or anxiety preceding their head injury, they're going to take longer in terms of their recovery, in terms of all the post-concussive symptoms, that their recovery trajectory takes significantly longer. But again, sort of my point that these 2 things go hand in hand. I will breeze through this. This is just a study that we did in the immigration detention context, where we found that neuropsychiatric conditions were the 2nd most common medical condition in this population. So really important to think about. And in the detention context, a lot of these things can be exacerbated, whether someone is subject to solitary confinement, for example. In the sample, we found that about 1 in 5 folks who had a medical condition reported an interruption to their medical care. So we know that, that can lead to significant worsening. And we also know people who are in detention or incarcerated settings see accelerated aging. There's a whole sort of area of research around that, but to think about this element of the migratory experience that some people may be subject to here in the US or abroad as influencing their immediate neurocognitive and neuropsychiatric outcomes, as well as long-term neuropsychiatric and neurocognitive outcomes. And then just to wrap up in terms of implications for care, I'll just want to go through the universal screening of trauma for the sake of time. And these are, I have an ongoing study that's looking at how to optimally treat traumatic brain injury with and concurrent psychiatric issues in refugee and asylum seeker populations. And these are just quotes from focus groups we had done with providers on their perspective in caring and addressing this issue in this patient population. So this person says, again, I think assuming universality is really important and a fair assumption to make for this population. When I ask about head injury, it almost always the response is, well, I don't know, I was just being beaten, or yes, there were definitely times, but it's hard for people to put their fingers on it sometimes if they've experienced such traumatic abuse. So approaching somebody just like we do with trauma-informed care, like this universal prevalence of exposure to head injuries probably is fair to do in this population. And this other provider who says, I think universal screening is a way of avoiding the shame piece. And she says, I would guess that most women who've been abused in some way are not going to offer that information up, right? That they're not. And that's why I think in the past, these people would be seen in therapy for years or by different people, and no one ever asked. And then something would come up and they would say, yes, that happened to me all the time. And you would think, well, why didn't you tell me? And the person would respond, well, because it's embarrassing and shameful and nobody ever asked. And they may not have thought that it had any significance to their functioning or the way they feel. So again, that these experiences might not be something that people talk about and offer, but I think to just adopt in asking about potential exposure, particularly to head injury, but detention, torture, sort of what I talked about across the continuum of care would really help us more holistically sort of address issues in this patient population. And then for the legal system, right, there a lot that relies on people's cognition to determine their asylum claim or their refugee claim. And this particular study we did, and we found around a third of this sample of 200 some asylum seekers reported memory issues, and that people who had depression and PTSD were almost 2 to 3 times more likely to have memory issues. And you can think that if someone's legal case is contingent on having their credibility be assessed on whether they can relay a story in a chronologic order and filling in all the details, may not sort of go hand in hand with what we know about the biology of both physical and psychological trauma and the way that it impacts memory and how people relay information. So I think this really, there needs to be a lot more education in terms of and partnering with legal partners, with agencies that are in the business of doing these credibility assessments, because we need to make sure that that's much more evidence-based and encompassing these people's neuropsychiatric reality and background. So I think that's it, and I'm really looking forward to the questions. I know this is a very broad overview, and probably could have, I actually had to whittle down an hour-long talk for this to make it into this short period of time, so that, so feel free to also email me if we don't get to it in the Q&A, or if you'd like to discuss any of this further.
Thank you so much, Altaf, for this brilliant talk. I know this is just one side of you being a physician activist and very active in this field and a role model for many of us. So I'd like to hear more from you, Altaf, beside what you have told us about the, specifically this very specialized domain of a set of multiple health challenges for that refugees face when they arrive in the United States. We've been hearing throughout the day from multiple speakers on child separation, from policymakers, from community partners, from providers. But from your experience in Boston, can you tell us more about what can be done? And just zooming out, not as a neuroscientist or neuropsychologist, or a neurologist in your case, what can others do, given that the audience is from many parts of the world and different disciplines?
Yeah, so I think the one element which I had mentioned was really trying to incorporate universal screening of asking around these exposures, particularly like head injury. I think oftentimes in intake, and this is something that I've been relatedly just been working with partners just in the intimate partner violence community, right? And also in the prison context where people have this exposure, but unless you ask, you don't know how that might be impacting their care. So even let's say in the domestic violence context, right, that they might be exposed to head injury. If you find out that that was a potential exposure and that they have trouble with memory, or that they're having trouble piecing these pieces together, then the information that you give them, right? Sometimes we say, oh, we're flooding them with information in their intake, or we're flooding them with information in their second visit. But if they've had that sort of context where they might have trouble with process, how fast they process information, right? That's something that we see after head injuries, for example, that they might need to be presented with information in fewer sessions, in a more simplified manner. But I've seen this really being much more developed in the intimate partner violence context. And I would really love that to sort of see it in the refugee health context, where as part of the intakes that we do, that's something that we should just universally ask someone and ask them about, particularly cognitive issues that they may be experiencing. One element.
Thank you. One more question, Altaf. Is there a link or tool you could share for assessing TBI?
Yeah, so the gold standard is the Ohio State University TBI assessment. That probably takes about less than 5 minutes. I think a more, even shorter, is one that's called the HELPS, HELPS, and then you can look TBI. And again, that's been used in the IPV survivors context a lot more. Actually, one of the things I'm hoping to do is to validate a TBI sort of assessment toolkit in this population. So those are the ones that I'd recommend now, and then I'll keep you posted about the future in terms of adaptations, because I do think that when I've used those screening tools, that there are parts that are missing. So I from those screening tools that I think are missing, but I think those are ones that could be used now.
Perfect. We have another question, Altaf. As a physician, how do you manage your clinical work roles with activism? I want to be a physician while advocating for equitable healthcare access to under-resourced communities. And I was just wondering, what are some ways that you get involved with activism while being a physician?
I think that, and I'll say sort of advocacy, I think it's recognizing that can happen on so many levels, right? That even at the individual level, as a physician, you're often your patient's advocate. That's what you do, whether it's trying to get them access to medication, and fighting with an insurance company, which I often do, right? Or trying to advocate for them in terms of with a particular provider. So I think there's always that individual level advocacy that's being done. But then I think for me, I think it's just really important to recognize that we need to be thinking about structural and policy issues. And I think that's where really community partnerships is so important. And I know that that's something that's dear to you, and obviously what speakers have spoken about before, but even in terms of what research questions we're asking, right? We need to be partnering with community organizations to say, look, this is something that we're coming across and we don't know what to do. So even the paper I had mentioned that was around the memory and the cognitive impairment using the Physicians for Human Rights data was really a question that had come to us where the legal partners were just saying, this is something we come up with a lot. And it's a challenge when we are presenting these cases. You know, do you have data about this? And so even sort of the conceptualization of the research, in addition to how we carry the research, just really needs to be partnered so that what we're producing is relevant to people at the front lines and then can be used for sort of big P policy, whether, yeah. So I don't know if that answers that question, but whoever asked it, I'm happy to sort of continue that conversation because I think it is always a challenge. But when this work is, again, as mentioned, very personal to me. So it's just sort of something you just keep at it and trying to figure out how you can leverage your voice.
Perfect. Thank you, Altaf. Okay. I'm not seeing any more questions in Q&A. If you have any, please, you can directly reach out to Dr. Saadi. Dr. Saadi, can you type in your email address in the chat box?
I will.
To you, Gretchen.
All right, well, thank you everybody so much for attending today. A huge thank you to all of our speakers. We had a really nice mix today of, talking about kind of just this overarching view of, of refugees and asylum seekers. We had clinicians providing direct care to asylum seekers and refugees, and also hearing about some of the epidemiology and policy. So it was a really nice mix that I think, and as well as from our community health organizations. And so it was a really nice mix to kind of give a very holistic view, in the couple of hours that we spent together. So thank you again to all of our speakers. And just some kind of last minute housekeeping. Everyone who signed up for the symposium today will receive a link to an evaluation for the symposium. So we do appreciate if you can take the time to fill that out. It actually should probably have arrived a few minutes ago in the email that you registered under. So again, please, we appreciate you filling that out. And once we're done pulling down the recording and get it up on the website, it will be on the Center for LifeCourse and Vulnerable Population website, which I posted the link to that in the chat as well. There you can see some of the other activities that that CLVR does that I spoke about in the introduction, and we'll continue to update that and get our new member and new associate director profiles on there. And please feel free to reach out to Tala or I if you have any follow-up questions, would like to be connected with any of the speakers, have any suggestions for research or to continue the discussion, we would be happy to do that. So thank you again to everybody for attending today, and take care.